Good evening, guys. I hope I'm audible. If I'm audible, let me know, please. I hope there's no echo as such, a lot of it. Just a minute. Hopefully, now it's fine. There's no echo as such, and I'm audible as well, right? Okay, great then. If I'm audible and the visuals are also fine, then we can start. Okay? So I hope all of you will keep on answering and correcting all the questions. So good evening all of you. I'm here. I'm Dr. Omkar Sangita Dilipra Sonone. I'm here for the FMG Jan 2023 recall questions. We'll be discussing most of the questions today itself in this session, and I hope all of you will be correcting, because please remember the questions that I'm framed over here, or the questions I have come up with, these are purely recall based questions, okay, from the information that I've gathered from all of the students. So based on that, these questions are being prepared, all the options and everything. So if the language is not exactly the same, please bear with me, because the language would be similar to the exam question. If you feel that the language can be more exact, please try to correct me at any point of time. Okay, so with this we will move further. Thank you to all the students who have helped me gather this information, so that we can have these recall question session today. Okay, chalo, without any further delay, let's begin our session. First of all, if I talk about this question, that was a straight one liner. I know, first of all, talking about the exam, uh, please remember, guys, yes, the exam which was conducted, the Jan 2023 exam, definitely that was a bit of a moderate exam, moderate to difficult, I would say, and difficult for only reason that the topics, I would say, they were not very uncommon. The topics were common only, but the framing of the questions was definitely uncommon. This time the options which were given, they were very close to each other. Okay, that used to happen in NEET or INA CT exams, but now definitely, as expected, it has started in FMG exams too. So it's always better to, like I've always told you, to be prepared very thoroughly for any of your exams. Okay, and now the exam is becoming more and more conceptual and clinically oriented. It was there from the August examination itself. Now it's becoming more and more conceptual. Okay, but along with that, definitely you don't need to forget the importance about the one liners as well. So all the FMG aspirants who will be attempting the upcoming FMG exam or the next exam, please remember, now it's also important to give due importance to the one liners as well. Okay, and I hope there were around 10 to 20% previous year questions or previous year topics which have been repeated, so there would not have been any issue as such for you to answer the questions. Definitely all of that, whatever it was, like, definitely we are here to get the recalls. Okay, but even in case you are not able to get the correct recalls of most of the questions, that's fine, absolutely, because please remember, guys, the questions that we are getting over here will not be the exact ones which were there in the exam. So even if one word is changed, definitely the answer can be changed. Okay, so most of the people have given us the recalls, and based on that we have framed our questions. But sometimes it happens, like, maybe the whole world is wrong, like most of the students are wrong, but certain students, are few students who are not able to tell the recall properly, but they have marked the answer correctly as well. Okay, so if you are not able to get the answers properly, there is no issue in that as well. Hmm? I hope the audio is fine as well. So if the audio is fine and the visuals are clear, I can move further with the discussion. And let's start with the first question. So let's start with the first question. Okay, great. Chalo then. The first question, I hope it's visible on the screen now. Please correct me if possible. The question was 100 minus 7 test is used to assess. So this was the question. This was a psychiatry question, and some people are saying it was in paper 1, some are saying in paper 2. Does not matter any which ways, because we need to answer it correctly, and that's more important. So the question was 100 minus 7 test is used to assess. So please remember, yes, this 100 minus 7 test is nothing, but it is called as a 7 subtraction test. Very good. So it is what is called as a 7 subtraction test. Okay, you ask the patient to minus or to subtract 7 from the number 100. Okay, and if we ask the patient to do it repetitively, okay, if we ask the patient to do it repetitively, then it is called as a serial 7 subtraction test. That means you will ask the patient to subtract 7 from 100, it becomes 93. Then you will ask to subtract 7 again, it becomes 86. Okay, then you will ask the patient again to subtract it. So if the patient is answering it correctly, that means his attention span is quite good. Okay, so please remember this 7 subtraction test, or the serial 7 subtraction test, it is used to assess the attention of the patient. It is used to assess the attention of the patient. That's most important. Okay, so that's important. Okay, orientation, language and knowledge के लिए नहीं होता. The 7 subtraction or the serial 7 subtraction test is definitely used to assess the attention of the patient. That was a clear one. Okay, important one liner. No issues with this, anybody? So this, please remember, the 7 subtraction test or the serial 7 subtraction test is a part of the mental status examination also sometimes, if you need to assess attention of this patient. Okay, if you need to assess the higher mental functions like attention or concentration, for that you generally use this test. Okay, moving further with the second question. This second question, it states, in a village, as a medical officer, you will educate people regarding washing wound after dog bite by which of the following method? So here they wanted to ask you about the methods of health communication. We have discussed there are 2 modes of health communication. Either one is one-way method, that is called as didactic method of health communication. The other is a 2-way method, which is called as a Socratic method of health communication. We know that, right? So there are certain examples of didactic methods or one way, that is something like a newsprint, a radio, a TV channel, or for example a flannel graph or a lecture. But for Socratic, there are multiple ways. Okay, so it can be a panel discussion, a symposium, a workshop, a demonstration, a focus group discussion, interpersonal communication. So these are all ways of 2-way or Socratic method of health communication. So here what we need to do, here we need to make the public or the people aware, or to educate them regarding washing wound after dog bite. Okay, which is the first step after dog bites. Okay, so we need to wash the wound thoroughly with soap and water for 15 to 20 minutes. So these people, usually if they are in a rural area or in a village, as they have mentioned over here, these people or the public would be generally uneducated, or they would be illiterate. So to make them understand in a very easier manner, what we will do, we will try to demonstrate it in front of them. Okay, we will actually try to watch it by ourselves first, and then we will call somebody from the public, okay, from the audience, and then we will ask them to do the same thing. Okay, so that is what is called as demonstration, that we have discussed already in all of our sessions. Now please let us know, guys.
ये तो कैसे ब्रेक हो रहा है, काफी ब्रेक हो.
Now I hope it's fine. Okay, good now. Chalo, great. Just a minute. Just spare me a minute. उनकी स्ट्रीम रुक जाएगी. जूम की कोई दिक्कत लग रही है. हो गया. अभी स्ट्रीम देख लो एक बारी. आवाज चेक कर लेना. अभी ठीक है. So I hope it's fine now. So we were discussing about demonstration, right? And we discussed even in classroom as well multiple times that demonstration is based on two important principles or criteria. And what were those two principles? The first principle was seeing is believing, right? What you see, definitely you will believe it easily. And the second one was learning by doing. Okay, so if you ask somebody from the audience to come and join you and perform the exact thing that you have done, so definitely they will learn it faster. Okay, so learning by doing. So these are the two important mechanisms on which the method of demonstration is based on. Okay, chalo. Now with this, I hope we can move to the next question. Question number 3. And this question I have discussed it in PSM, even in chanting. You have been like this question was discussed in class also. Okay, so we have discussed it again and again. So I don't think so there should have been any problems in this. So this was about the Indian healthcare system, and here they have asked this time. So this was a previous year topic. I would not say it is a previous year question, but yes, it was a previous year topic because they have been asking about eligible couple earlier also. Okay, they asked about the eligible couple definition earlier. Once they asked about the target couple definition, and now they have asked like the eligible couple register is maintained at which level of healthcare. So first of all, please tell me the eligible couple register is maintained by which healthcare worker. I hope all of you are quite aware of that. So eligible couple, we all know who is the eligible couple. Eligible couple is the one whose wife falls in the reproductive age group. That means whose wife is actually in the 15 to 49 years of age group. Okay, so such a couple whose wife is in the reproductive age group of 15 to 49 years, such couple is considered as an eligible couple. And that eligible couple register is maintained by which healthcare worker? So we know it is maintained by the multipurpose worker female. It is maintained by the multipurpose worker female, right? So important functions of multipurpose worker female were: 1, she can conduct delivery. Okay, if the doctor is not available, definitely at the level of sub-center, either an A&M or the multipurpose worker female can conduct a delivery with the help of a traditional birth attendant, right? Second, please remember, she is also responsible to maintain this eligible couple register. Okay, so important things. And multipurpose worker male, we have discussed an important function of multipurpose worker male also. He is responsible for preparation of the slides of malaria, which are further examined at the level of PSC, right? So that was also previous year question. So please remember, as multipurpose worker, she is located at which level? You are right. Multipurpose worker female is located at the level of sub-center. So therefore eligible couple register is also maintained at the level of a subcenter itself. So answer would be option C over here. कोई दिक्कत नहीं है इसमें. Now let's move further. ठीक है. Question number 4 now. Please keep on completing the options. अगर तुम्हें options पता है, please help me out to complete the options as well. Okay. So here the question was straightforward, a biochemistry question. There was no doubt in the question itself. Okay. So this was a very straightforward question. They did not even mention a case. So they directly asked which enzyme is deficient in von Gierke's disease. Now some people are saying the other options were usually enzymes, but some people are saying the other options were names of some syndromes. So I would like to ask you, what were the other options, if you could please recall them. Okay. So which enzyme is deficient in von Gierke's disease? We know what is von Gierke's disease. It is the most common type that we have discussed. Okay. So it is discussed in pediatrics also, in biochemistry also. Okay. So in your notes as well as everywhere it is discussed in FMGE, right? So please remember, von Gierke's is the most common type of glycogen storage disease, whereas please remember it is a type 1 glycogen storage disease. Okay. What happens? Some enzyme in glycogen metabolism or glycogen synthesis is deficient, due to which what happens, there is excessive accumulation of glycogen. Okay. And this excessive glycogen can accumulate at various sites, most common being the liver and spleen, and therefore the patient can present to you with hepatosplenomegaly. Okay, the patient presents to you with hepatosplenomegaly. Okay, please remember. Other options were enzymes. Great. So if other options were enzymes, they would be something like this. Either one of the options would be glycogen phosphorylase. One of the options I had got, that was G6PD, glucose 6 phosphate dehydrogenase. Okay. If you are able to recall the other options, please add it up. Okay. So here definitely this excess of glycogen can accumulate at sites like the liver and spleen, causing hepatosplenomegaly, which leads to distension or protrusion of the abdomen in the child. Okay. Along with that, the patient will definitely have features of severe hypoglycemia. There would be recurrent attacks of severe hypoglycemia in the child, and along with that, the hypoglycemia would be so severe that there would be production and utilization of ketone bodies, causing ketosis in the patient along with lactic acidosis. So these are the features usually of von Gierke's disease, or a type 1 glycogen storage disorder. Please remember, all those who are upcoming aspirants, please remember, this is how you differentiate. These are the two important features with which you differentiate type 1 and type 6 glycogen storage disease. Type 1 is von Gierke's, where all of these features are seen, but type 6 is Hirsch disease, which is due to deficiency of hepatic phosphorylase, where ketosis and lactic acidosis will not be a feature. Okay, in type 6, ketosis and lactic acidosis will not be a feature. So definitely here we all are quite aware, von Gierke's or type 1 glycogen storage disease is due to deficiency of an enzyme called as option A, glucose 6 phosphatase. It is due to deficiency of glucose 6 break down into glucose. Okay, so that is the problem, and therefore the patient is not able to utilize it, because if it cannot enter glycolysis. No issues with this, anybody? That's important. Okay. Question number 5 now. This was a question from GVP. Yes, definitely ECG was not there in the question this time. ABG was not there. Electrolytes were not there. Yes, definitely the most expected topics of medicine were not there, definitely. But one of the commonly expected topics is JVP as well, and JVP had come this time as well. Okay. So we are quite aware of JVP waves. Okay, what is JVP? It is jugular venous pressure, which is actually measured from the internal jugular vein, and there are few waves that you can see. Okay, if there is increase or decrease in the pressure in the internal jugular vein, these pressure are actually reflected by some waves or some descents. So first one, as we know, it is the A wave. Okay, second one is the C wave, next is an SX descent, then we have a V wave, and finally we have a Y descent, right? So here we have mnemonics for everything. A wave is definitely due to atrial contraction. Okay. Then C wave, please remember, this C wave is due to, we have discussed, it is due to isovolumetric contraction. C stands for contraction. X stands for ejection, right? So X is for ejection period. V stands where vena cava fills the atria, right? V for vena cava filling the atria. So whenever there is an atrial filling which takes place, that is responsible for the V wave, because when vena cava will when vena cava sorry, we drop the blood into the atria, what will happen? The intra-atrial pressure will rise. The pressure within the atria will rise. And if the pressure within the atria rises, if the pressure within the right atria rises, the same pressure would be elevated in the internal jugular vein as well. And therefore, due to this positive pressure, there is a positive wave which is seen, and that is what is called as your V wave. And lastly, we have the Y descent, and this Y descent is due to atrial emptying. All of this we have discussed earlier, right? Now please remember, important is they have asked where we can find a giant V wave. A similar question I have discussed it in the test and discussion session also. Definitely Manish sir have discussed this with you in great details in medicine, but even we have also discussed this JVP changes in one of our medicine questions, and there was a very similar question of this kind. Okay. So please remember, giant V wave is seen in which condition? Giant V wave क्यों होगा? Because there would be increase in the right atrial pressure, and during which period? When the vena cava are filling the atria. So V wave is due to vena cava filling the atria. So whenever the vena cava are filling the atria, there is highly elevated pressure in the right atrium, due to which we can get a giant V wave. Therefore we can get a giant V wave usually. Okay. और ये excessive pressure क्यों आ रहा है? Because please remember why there is so excessive pressure. Because please remember, when the vena cava filling the atria, they are bringing the blood from the body into the right atrium. But at the same time, what happens? Some amount of blood, okay, some amount of blood from the ventricle is also getting regurgitated into the right atrium. Okay, so some amount of blood from the right ventricle gets regurgitated into the right atrium. So what happens during this time? There is a highly elevated right atrial pressure, and due to that there is an increased internal jugular venous pressure, and that what leads to a giant V wave in JVP. No issues with this. So here the answer should be definitely option A, straightforward, that is option A, that is tricuspid regurgitation, right? So due to tricuspid regurgitation, guys, there is more amount of blood in the right atrium, therefore more amount of pressure is generated in the right atrium, which is same exerted in the internal jugular veins, and that is why a giant V wave is obtained. No issues with this, please remember. कोई दिक्कत नहीं है इसमें. I hope this was fine. Please remember, yes, कुछ लोग पूछेंगे pulmonary stenosis. Please remember, pulmonary stenosis at times can lead, but on a very long term, and it will not lead to a giant V wave usually. Okay, it can lead to a large V wave, but not a giant V wave. There are two different terms, please remember. Okay, and pulmonary stenosis to develop or to lead to a giant or a large V wave, it will take a lot of time. Okay, some people are saying instead of pulmonary stenosis, tetralogy of Fallot was an option. So one and the same thing. In tetralogy of Fallot also, like the cause behind this would be again pulmonary stenosis itself, right? So please remember, whatever was the option here, the best answer would have been tricuspid regurgitation amongst all the options that were given to you. No issues with this, anybody? Okay, please remember. Chalo. Please keep on adding if you have any other things to say, if the question was not framed in the right manner, or if you feel the options were something different, please feel free to add it up. Okay, question number 6 now. Here, this again we have discussed, definitely anatomy में भी discuss किया होगा sir ने. We have discussed it in surgery as well. So while performing endoscopy, a narrow point was felt at 25 centimeters from the upper central incisors. Okay, so once you enter with the help of an endoscope, okay, from upper central incisors, if you measure the distance, you usually feel some constrictions in the esophagus. Okay, and these are generally 4 constrictions. Sometimes they are referred to as only 3 constrictions. Okay, so if we consider the upper central incisors at the reference point, so first constriction that we meet usually in the esophagus is at the level of C6. The first constriction is at the level of C6. Okay, and it is 15 centimeters from the incisors. And this, please remember, is the first constriction. It is due to the upper esophageal sphincter, also called as the cricopharyngeal sphincter. Okay, it is due to cricopharyngeal sphincter or the upper esophageal sphincter. The first constriction 15 centimeters away from the incisors. Second constriction is usually 25 centimeters away from the incisors. It is 25 centimeters away from the incisors. It is at the level of T4, and it is seen when the esophagus is crossed by the arc of aorta. It is seen when the esophagus is crossed by the arc of aorta. Next constriction is immediately seen at 28 centimeters, to be specific 27.5. Okay, it is immediately seen at 28 centimeters or at T5 level, and it is due to bronchial constriction. That means when the esophagus is caused by the left mainstem bronchus, when the esophagus is crossed by the left mainstem bronchus. Okay. And lastly, the fourth constriction, it is usually seen at the level of lower esophageal sphincter. It is seen at the level of lower esophageal sphincter, or we would say when the esophagus goes into the diaphragm. It is seen at level of T10 and it is 40 centimeters away from the incisors. So here definitely they have asked which like there is a constriction or a narrow point which is felt at 25 centimeters from the upper incisors. This constriction is generally due to. So what would be your answer over here? This constriction is generally due to. Very good. So here, if please remember, some people are saying that arc of aorta and left main bronchus or bronchus was in the same option. Okay. So if they were in the same option, that would have been the best answer. If अगर अलग अलग दिए हुए थे, please remember, if all the options were like this, which I have given over here, so please remember to be specific. Answer should be option C, arc of aorta. Okay. At 25 centimeters it is arc of aorta, and at 28 centimeters it is the left mainstem bronchus. कोई दिक्कत नहीं है. So to be specific, answer should be arc of aorta. कोई दिक्कत नहीं थी. I hope it was fine. Okay. So please remember. ठीक है. If you feel it was framed in different manner, so left mainstem bronchus, I am telling you, please remember, just beneath the arc of aorta where it crosses, just beneath that the left mainstem bronchus usually crosses it. Okay, so please remember, अगर 25 centimeters था, then arc of aorta is the best answer if all the options were different. If you need to mark one, please remember this. Moving further to question number 7 now. This also we have discussed. The best investigation, the gold standard investigation, the investigation of choice is one and the same for this given condition. Which among the following is the best diagnostic test for fistula in ano? Okay, so here they are actually talking about the perianal fistulas or fistula in ano, and we know the answer straightforward would be very good. So the answer straightforward over here is MRI. Okay, please remember, left main bronchus was in different options, so arc of aorta should be your best answer. Okay, no issues. So here please remember the best answer, the gold standard or the best investigation for fistula in ano is definitely MRI. Rather, to be specific, it is called as MR fistulogram. It is what is called as MR fistulogram. But in option, MRI was mentioned straight away, not MR fistulogram, I feel. Okay, so MRI would be the best answer. Please remember, because it helps us detect the whole tract of the fistula. Okay, whole fistulous tracts can be identified with the help of an MRI. Sinogram is nothing. Sinogram is a serial X-rays which are taken usually. Okay, so sinogram is also serial X-rays which are taken. But if we compare X-rays and MRI, I hope now the answer is very clear to you. Which are more sensitive? तुम्हें बता सकते हो. MRIs are definitely more sensitive, guys, right? So please remember, the soft tissues can be easily picked up on an MRI. So if you need to detect the whole fistulous tract, so it is always better to go for a better investigation like a MRI. So MR fistulogram is definitely preferred over a sinogram over here. Please remember, in sinogram, X-rays are generally done. Okay, कोई दिक्कत नहीं है इसमें. So here the best investigation would be MRI. No issues really, anybody? Image was not given. I've just given the image for your reference. ठीक है? So here you can see the one which is highlighted. Okay, so we inject definitely a contrast and then we take a MRI. So here you can see the fistulous tract is highlighted. Okay, that is what is the fistula which I see. Moving further, question number 8 now. What is the preferred management in a following case? Sorry, I just forgot to give you an X-ray, but I hope ये तो सरकारी question था, इतनी बार discuss कर लिया था हमने. Okay, we have discussed this question multiple number of times. And the X-ray which was given was actually a X-ray chest, right? It was a X-ray chest plus neck, and in that what was given, on the two views were given. One was a AP view and second was a lateral view. On AP view, there was a foreign body which was impacted. Okay, there was a foreign body which was impacted, and I've always told you how to differentiate between a foreign body in an esophagus and how to differentiate a foreign body in the trachea. Okay, ENT में भी discuss किया है, सर्जरी में भी डिस्कस किया है, चैंटिंग्स में भी डिस्कस किया है. सो आई डोंट थिंक सो यू शुड हैव मेड एनी मिस्टेक इन दिस. सो ऑन एपी व्यू, इफ द कॉइन अपीयर्स टू बी सर्कुलर, okay, on an AP view, if the coin appears circular, and on lateral view it appears slit like, definitely the site of impaction is the esophagus. Whereas vice versa, on AP view, if it appears slit like, and on lateral view it appears circular, then the site of impaction can definitely be trachea. But that was not the case. Okay, the case, one of the options was wait and watch. Was it an option? Because please remember, most of the people are recalling tracheostomy or cricothyroidotomy as an option. I definitely know. Please remember, sometimes what happens कि हम कहीं और का कुछ क्वेश्चन देख लेते हैं, हमें लगता है हाँ शायद ये भी ऑप्शन में था. तो तुम्हें जितना रिकॉल हो रहा है उतना बताओ. Was actually wait and watch an observation in the option? Because then the answer will definitely change, guys. Then the answer will surely change. So please remember, here definitely the X-ray chest plus neck was given. APV was showing a circular coin, okay, a circular opacity, whereas lateral view was showing a slit-like opacity. So site of impaction is definitely esophagus. Apart from that also I told you how to differentiate between an esophageal and a tracheal foreign body. हमेशा बोला है मैंने, अगर esophagus में foreign body है, if there is a foreign body in the esophagus, on a lateral view what will happen? In front of the foreign body you can get a black column of air. In front of the foreign body you can get a black column of air. So if this black column of air is seen, definitely please remember, then definitely what we can say, yes, this black column of air is a trachea and the foreign body is behind the trachea, so it has actually landed up in the esophagus. तो मैंने बोला था, अगर तुम्हें ये circular slit like याद नहीं रहता, the second reliable thing that you need to look on a lateral X-ray is definitely to check for this air column. If air column है और उसके पीछे foreign body है, definitely the site of impaction is esophagus. Now, if it was trachea, if the foreign body was impacted, like a coin was impacted in the trachea, definitely what would have been the treatment? Treatment we have discussed, usually it is an endoscopic removal that we do, right? It is an immediate endoscopic removal, because in tracheal foreign body, the patient can get usually a choking sensation, there would be respiratory distress, there would be aphonia, all of these features would be there, right? In esophageal foreign body, usually, definitely the patient has some foreign body sensation in the throat. Along with that, there can be dysphagia as well, okay? But there is no respiratory distress as such. So if the foreign body in the esophagus, तो हमने ENT में stepwise approach discuss किया हुआ है, right? We have discussed everything in ENT as well in the classes. So I have told you, in esophagus you need to assess whether the foreign body is above the cricoesophageal sphincter or it is below the cricoesophageal sphincter. Okay, please remember, if it is above the esophageal or the below the cricoesophageal sphincter usually. If it is above the cricoesophageal sphincter, cricopharyngeal sphincter, then definitely here you will go for an immediate endoscopic removal. You will go for an immediate endoscopic removal. But if it is below the cricopharyngeal sphincter, why? Because cricopharyngeal sphincter is the narrowest portion of the GIT, and if the foreign body or the coin has surpassed the cricopharyngeal sphincter, तो आगे तो आराम से travel कर सकती है. That we have discussed, right? So if it has surpassed the cricopharyngeal sphincter, then definitely here you will only go for observation, or we can say wait and watch. Along with serial X-rays are to be performed, right? Observation with serial X-rays to find its progression, to find the progression of the foreign body कि अच्छे से travel कर रही है या नहीं कर रही. Okay, so that is how you need to answer it. So please remember, if I am just giving you Hemlick's maneuver, एक तो लोगों ने mark किया है. I've always told you Hemlick's maneuver is usually done when there is a choking sensation in the patient. Usually then when there is an impacted food material. Please remember, when there is an impacted food material in the trachea or the larynx. Okay, so please remember, for that, what happens due to Hemlick's maneuver? We are giving upward and backward thrust on the epigastrium. Okay, due to this upward and backward thrust on the epigastrium, the transglottic pressure increases, and as the transglottic pressure increases, due to this increased pressure, the foreign body is thrown out. Okay, so that is usually done for a tracheal foreign body. Okay, not even for a tracheal, I would say it is mainly done for a laryngeal foreign body, mainly like a food material, impacted food material. That is not done for a coin any which ways, and not in the esophagus at all. So here, if this was the options, definitely esophagoscopy would have been your answer. Esophagoscopy is nothing. जब भी तुम endoscope जिसी भी organ में डालोगे, that would be scopy, right? If you insert the endoscope in esophagus, it is esophagoscopy. If you insert the endoscope in bronchus, it is bronchoscopy, right? So please remember that. Here it is esophagoscopy. So endoscopic removal or esophagoscopic removal of the foreign body or the coin should have been done. कोई दिक्कत नहीं है इसमें. And if this was not the option, if you had one other thing in option, instead of tracheostomy, you had observation or wait and watch, whatever. Okay, observation or wait and watch. Whatever. Okay, or wait and watch, please remember. So ये so then here answer would change. Why? Because please remember, if usually the foreign body you can see on X-ray of chest, okay, if you can see the foreign body on the X-ray of chest, then definitely the site of impaction is below the cricopharyngeal sphincter, and then definitely we will go for observation or wait and watch as the best treatment. Okay, then we'll go for observation or wait and watch as the best treatment. कोई दिक्कत नहीं है. So please remember, अगर X-ray chest पे foreign body दिख रही है, definitely it has surpassed the cricopharyngeal sphincter, and then your answer changes to wait and watch or observation, whatever it was in the question. ठीक है? So please remember, depending on the framing of question, the answer would change over here. ठीक है? Question number 9 now. Hand washing for COVID-19 is which level of prevention? A similar kind of question I have discussed. Okay, मैंने एग्जाम के पहले भी एक वीडियो डाला था ग्रुप में. Okay, and this we have discussed levels of prevention. We have discussed multiple number of times. There were 2 questions this time on level of prevention. I'll be discussing the other one too, but this was one of the easiest questions, and I hope all of you have marked it correct. ठीक है ना, किसी ने गलती ना करी. Hand washing for COVID-19 is which level of prevention? So we know COVID-19, please remember, COVID-19 usually spreads by a respiratory droplet, and these respiratory droplets definitely can infect our hands as well. Okay, so therefore to prevent that, we need to wash our hands thoroughly. Okay, we need to wash our hands thoroughly. So definitely the risk factor is present. Okay, the risk factor is present, and to prevent the spread of the virus, or to prevent the spread of the disease, we are actually washing our hands. Okay, so definitely this is which level of prevention. If the risk factor is present, it is always and always primary level of prevention. Which one? There are 2 types of primary level of prevention. One is health promotion, other is specific protection. तो अगर ये पूछा होता तो what would have been your answer? So primary level of prevention can be either health promotion or specific protection. So hand washing would be which kind of level of prevention? It is definitely primary level of prevention, because the risk factor is present, and therefore to prevent the disease from transmission, we are actually washing our hands. Use of sanitizers, we have discussed all of this. Washing hands, use of mask, use of sanitizers, all of this is primary level of prevention. It would be specific protection. याद रखना. No issues with this anybody? To prevent the spread of the disease or to prevent the transmission of the disease. So it is specific protection, primary level of prevention. कोई दिक्कत नहीं है इसमें? Great. Moving further. This was an easy question. Question number 10. Here I feel ET tube image was given as well. Right? Endotracheal tube की image दी हुई थी. So there was a ET tube image. Now the question was ET tube resistance is dependent on. Now please remember, this was a recall NEET PG question. Okay, so this was a recall NEET PG question. इसीलिए मैंने बोला था कि NEET के लास्ट के 2 साल के क्वेश्चन, शायद ये NEET 2021 का क्वेश्चन था. So this was a recall NEET 2021 question, and this question was ET tube resistance is dependent on which of the following parameters or factors, right? So I hope the 4th option was cuff. I'm not sure about the 4th option. Please correct me if I'm wrong. ठीक है? So the options were length, curvature, diameter and cuff. अगर फिजियो किसी ने पढ़ा होगा कभी जिंदगी में, या फिर फिजिक्स पढ़ा होगा, तो रेजिस्टेंस इज इक्वल टू 8 न्यू एल अपॉन 8 न्यू एल अपॉन पाई आर 4. Please remember. Okay, and if they ask you resistance, this was a previous year question. So resistance is inversely proportional to the radius, and radius is what? Radius is nothing but the half of the diameter. So diameter is double the radius, or radius is half of the diameter, whatever you call it. ठीक है? So please remember, over here you need to remember that this is important. Okay, air resistance was the 4th option. Okay, air resistance was the 4th option. Please remember. So here we know resistance is inversely proportional to the radius of the tube या diameter of the tube. So if the, तुम्हें यार एक बहुत basic logic है, common sense की बात है. If the diameter of the tube or the radius of the tube is smaller, definitely the resistance would be higher, right? So please remember, if the diameter of the tube is smaller, the resistance, okay, would be higher, definitely. So here ET tube resistance is mainly dependent on the diameter of the endotracheal tube. So if diameter is small, the resistance would be high. If diameter is large, the resistance would be low, right? So this was a straightforward question. 4th one was radius. I doubt this would have been your option. because अगर radius होता then your answer would have been radius. In question they have asked about air resistance. Okay, got it. So air resistance wasn't an option, it was air resistance is dependent on. Okay, so air resistance is dependent on, and radius was the option, right? So if radius was there in the option, then radius would have been your answers. All options was correct. I am not getting that recalls from most of the people. Like very few people have told me all of the above was an option in any of the questions as such. So अगर all of the options are correct, ये option था या नहीं था? Because the previous year question that they have asked in NEET PG also, that was a straightforward. The radius was the option which was given in the earlier question as well, in the PYQ as well. So please recall it properly. If radius was the option, radius was not there, right? Okay. So it was diameter. So please remember, diameter would be inversely proportional, or radius would be inversely proportional to the endotracheal tube or the air resistance. No issues with this, anybody? That's important. Please remember. Okay? Question number 11 now. This was a question of ortho or applied anatomy as well. Okay. So the question number 11, it says a patient was asked to stand on his left leg and his right hip falls down. Which among the following muscles are affected? Okay. So we know this is which test the examiner has asked the patient to perform. Yeah, I have that question. Thank you, Lakshman. I have that question. We will discuss that as well. Don't worry about that. Okay, that was about Ringer's tumor. Definitely we'll discuss about that as well. Okay, so please remember, a patient was asked to stand on his left leg and his right hip falls down. This is which test? This is definitely called as your Trendelenburg test. Okay, this is what is known as your Trendelenburg test or Trendelenburg sign. Okay, and please remember, Trendelenburg test or Trendelenburg sign was actually a test used to assess the function of the hip abductors. It is used to assess the function of the hip abductors. And which two muscles are hip abductors, anybody? Which are the two important hip abductors? One is gluteus medius and the other muscle is gluteus minimus. Okay, so please remember, left side affected, no issues. They didn't mention sides in the options, right? So there wasn't an issue with that. Okay, अगर वो side mention करते options में, then it would have been confusing. उन्होंने तो साफ साफ बस muscles के नाम पूछे थे, right? Those which were involved or affected. So here, whatever it was, if it was like on lifting the right leg, the option would have been something, the question would have been something like this. Okay, on lifting the right leg, the left hip of the patient falls down, right? Vice versa. It is one and the same thing. They mentioned the side in options. So then definitely it's important to correctly frame the question. Okay, so right, left was there in the options as well. Okay, got it. So please remember, if that was in options, we need to check the question once. So I hope now the question I've corrected, it is true. See, a patient was asked to stand on his right leg and his left hip falls down. Which among the following muscles are affected? Right? Was this the question? I have changed the sides now in the question. Please correct the question once if this was the question. No issues with this, anybody? So if I talk about the Trendelenburg test or the Trendelenburg sign, I hope all of you are quite aware of this. Okay, here. So here, if I am asking the patient to lift his left leg, okay, in the image, if the patient is asked to lift his left leg, please remember, okay, and so this image should have been proper. Okay, if the patient is asked to lift his right leg, okay, if the patient is asked to lift his right leg and the left side of the hip falls down, so what does it mean? So please remember, what does it mean usually? So here, please remember, if the patient was asked to lift his right leg and the right side of the hip falls down, matlab the opposite side hip abductors are weak. The opposite sided hip abductors are weak because they are not able to maintain the hip in a neutral position. Okay, so please remember, the neutrality of the hip or the neutral position of the hip is actually maintained by the hip abductors when the patient is asked to raise the leg. Okay, here if the patient is asked to raise the left leg, the right leg and the right hip is falling down, definitely we can see the opposite sided hip abductors were weak. Okay, the opposite sided hip abductors were weak usually. No issues with this, anybody? So it was left side which was affected. Right, left was there in the options. Okay, I understood that. Okay. So please remember, as I've told you, if they mentioned the patient was asked, please remember, the patient was asked to stand on his right leg and his right hip falls down. Which among the following muscles are affected? Right? This was the question. Now, if this was the question, we know when the right hip falls down, definitely the opposite sided hip abductors are weak usually. Okay, the opposite sided hip abductors are paralyzed, or the opposite sided superior gluteal nerve is paralyzed. Okay, so the opposite sided or the contralateral superior gluteal nerve is paralyzed, due to which the innervation to both these muscles, gluteus medius and gluteus minimus, is not there, and due to which these two muscles would be paralyzed. So it is always contralateral. अगर right hip dip कर रही है तो left side is affected. अगर left hip dip कर रही है तो right side is affected. So here, if the right hip was falling down, answer should have been left gluteus minimus and left gluteus medius. No issues with this. Okay, please remember. And if left was affected, vice versa. Okay, if left side was affected, then right would have been your answer. ठीक है, कोई दिक्कत नहीं है इसमें. प्लीज रिमेंबर, वाइस वर्सा याद रखना है, कॉन्ट्रालैटरल या अपोजिट साइड अफेक्ट होती है. तो अगर राइट हिप वाज फॉलिंग डाउन, आई एम जस्ट टेलिंग यू ओवर हियर, ठीक है, इफ राइट हिप वाज फॉलिंग डाउन, देन द आंसर वुड हैव बीन लेफ्ट ग्लूटियस मीडियस एंड लेफ्ट ग्लूटियस मिनिमस. अगर क्वेश्चन दूसरा था, इफ द लेफ्ट हिप वाज फॉलिंग डाउन, और ड्रूपिंग डाउन, then the answer should be right gluteus medius and right gluteus minimus. कोई दिक्कत नहीं है इसमें. This we have discussed as well. ठीक है, तो अभी कोई दिक्कत नहीं होनी चाहिए, इस पे बेस तुम्हारा आंसर होगा. राइट, चलो आगे बढ़ते हैं. क्वेश्चन नंबर 12 कॉमनली रिपीटेड, और इसमें अगर किसी ने गलती करी हो ना भाई, तो I seriously feel this was a blunder that you have did. ठीक है, इतनी इजी क्वेश्चन में गलतियां नहीं होनी चाहिए. What does S stands for in safe strategy? Safe strategy is used for which ocular pathology or which disease in ophthalmology? It is definitely used for okay, no issues with that. ठीक है. Okay, so safe strategy is definitely used for a condition known as trachoma, also known as Egyptian ophthalmia or chlamydial conjunctivitis, that we have discussed multiple times, right? So WHO has given a safe strategy for trachoma, and here S definitely stands for, we have discussed all safe, right? So S over here definitely stands for surgery, और ये भी डिस्कस किया था हमने. S stands for surgery, and surgery is done for which condition or which feature of trachoma? That too we have discussed. It is the surgery is actually done for the misdirected cilia, and these misdirected cilia are what are called as trichiasis. The misdirected cilia are what are called as trichiasis. Please remember, right? Very good. So here A definitely stands for antibiotics, and the drug of choice which is given, or the antibiotic of choice which is given in trachoma, is azithromycin. Very good. F definitely stands for facial cleanliness. And lastly, E stands for environmental sanitation. Okay, E stands for environmental sanitation. No issues with this, anybody? So that's important. Okay, that is what is the safe strategy which is used for trachoma. Okay, so please remember this. Okay, so here S was for surgery. That was very easy, which is done for the misdirected cilia or trichiasis. Spectacle signs and symptoms are not any options. Okay, I'll do that as well. Don't worry about that. Okay, I'll try to cover that one. Question number 13 now. Identify the below given diagnosis. A most easiest question, spot diagnosis only with the help of an image. First of all, the bone appears white. Definitely it is a NCCT which is there. Okay, and here it is a NCCT head which is given. And NCCT head pe, if you can see some whitish opacity or some hyperdensity, that is definitely suggestive of some bleed or some hemorrhage. Okay, and here which kind of opacity or which shaped opacity is seen, you can just see it. If I can highlight it, this is the idli shaped opacity as you call it usually, or it is called as a biconvex opacity, or what we call is a lens shaped or a lenticular opacity. Intracranial hemorrhage में अगर किसी ने गलती करी होगी ना भाई, please remember that We have discussed this question so many times. Okay, so please remember, biconvex or lenticular hyperdensity on a NCCT head is definitely suggestive of which kind of intracranial hemorrhage? It is suggestive of extradural hemorrhage. Okay, it is suggestive of extradural hemorrhage. There was one more question about subarachnoid hemorrhage as well. Most of the people are giving me a recall of SAH also. So I'll come to that question as well. So there were two important questions from intracranial hemorrhage. So this is one of the important questions or topics in the examination, in any examination for that matter. Okay, please remember. So here a biconvex or a lenticular hyperdensity was seen, which is suggestive of a EDH or extradural hemorrhage, which is usually due to rupture of which artery? It is due to rupture of the middle meningeal artery. And what is the landmark? The landmark for this is the pterion. And therefore the burr hole surgery, okay, which is performed in cases of EDH, it is actually performed at the level of the pterion itself. No issues with this, anybody? If it was a banana shaped opacity or a concavo-convex opacity or a crescent shaped opacity, half moon shaped opacity, then the answer would have been subdural hemorrhage. Subarachnoid hemorrhage may we know the hyperdensity or the opacity is generally seen in two things. First, in the ventricles we can see the opacity. These ventricles will no more appear black, they will appear white. And second, the Sylvian fissure appears white. So if ventricles and Sylvian fissure are appearing white, then it was SAH. Okay, an intracerebral hemorrhage, that means there is some hyperdensity or opacity in the brain parenchyma itself. Okay? I hope this was a very easy question, so nothing much to discuss. Question number 14. Again, Sarkari question, repeated multiple number of times. Important topic, contraceptive, PSM, OBG overlap. Discussed multiple times. Previous year question straight away. Copper T 380A, which is the most commonly used IUCD in the Indian healthcare program, has a shelf life of how many years? Okay, or has a shelf life of, I hope this was very easy for all of you. Usually the IUCDs have a shelf life of 3 to 5 years. But Copper T 380A is generally used in Indian healthcare program because it has a higher shelf life as compared to the other IUCDs. Okay, and that is the reason why we use it commonly, and the answer to this question would be option B, 10 years. Okay, so please remember, Copper T 380A generally has a shelf life of around 10 to 12 years. Single best answer would be 10 years usually. Okay, single best answer is 10 years. कोई दिक्कत नहीं है इसमें. Please remember. What were the other options? वो जो question था skeletal maturity वाला, please try to recall the options as well. If options are there, I'll try to give you the answer as well. Okay? चलो, question number 15 now. Lacrimal sac is present in which wall of the orbit? Again, a very easy and a simpler question. बस एक trick था, हाँ, one liner जरूर था ये question, but there was a trick in it because we know, please remember, the location of the lacrimal gland is different, the location of the lacrimal sac is different. तो जिसने गड़बड़ी करी उसने गलतियां भी करी होगी इसमें. प्लीज रिमेंबर, जस्ट अ मिनट गाइस. Just a minute, I'm joining in. Okay. I don't think so there would be an issue as such now. Chalo. Now moving back to our question. So here please remember, we know the lacrimal apparatus. If we discuss the lacrimal gland, it is actually located on the lateral wall of the orbit. Okay, the lacrimal gland, I am saying, it is located on the lateral wall of the orbit. Okay, from here please remember, in the lacrimal gland there is tear production which takes place. Okay, then these tears usually, okay, they take part in the tear film. Okay, and once that function is done, they usually travel via these punctum. ये दो जो होते हैं वो punctum होता है, and via these punctum into the upper canaliculus or the lower canaliculus, from there into the common canaliculus, and then they actually enter into the lacrimal sac, and from lacrimal sac it continues into the nasolacrimal duct, NLD जिसको बोला था हमने, it goes downwards, outwards and backwards, and then finally opens into the inferior meatus on the lateral wall of the nose. But उन्होंने ये बाकी कुछ नहीं पूछा, they only asked the lacrimal sac, this one, okay. This structure, the lacrimal sac, is located on which wall of the orbit, not which wall of the nose. So it is located, as you can see, it is located on the medial wall of the orbit. Okay, so this was a straightforward, easy question. The lacrimal sac is located on the medial wall of the orbit. No issues with this, anybody? That was easy, I hope so. ठीक है? चलो. Moving further. चलो आगे क्वेश्चन नंबर 16. A child has accidentally drank. अब ये full bottle of iron syrup हो और the child has ate or eaten 10 tablets of iron ho. Okay, whatever it is, the case finally remains the same. The provisional diagnosis remains the same as well. Okay, so there's no issue in this. Previous year question discussed in pharma multiple times in our class as well. Okay, so a child who has drank full bottle of iron syrup or 10 tablets of iron the child has taken. Okay, so definitely the diagnosis over here is iron toxicity, and now they are asking what is the antidote of choice or the drug of choice for iron toxicity. So it was a straightforward question. They did not even ask you about chronic iron toxicity. They just asked you about iron poisoning or iron toxicity straight away. Okay, so definitely here the answer was option A, desferoxamine. Okay, so the answer was straight away desferoxamine, which is the antidote of choice usually, okay, for iron toxicity or iron poisoning. कोई दिक्कत नहीं है इसमें. I hope so. This was very easy. Penicillamine, as we know, okay, penicillamine is generally used for copper poisoning. जब copper excess हो जाता है, copper poisoning हो जाती है, then definitely we will go for penicillamine. Okay, and EDTA was a previous year question. Just a recent FMG June 2022 session में they asked about EDTA usually as well. Okay, so it is used for lead poisoning. No issues with this, anybody? I hope so. I have made myself pretty clear. ठीक है, चलो आगे. Question number 17, if I talk about. Question number 17 says, which among the following is an absolute contraindication of breastfeeding? A question that we have discussed in PSM, even in pediatrics. A question which was present in our test and discussion also. Previous year question है ये तुम्हारा FMG का. I don't think so. There should have been any mistakes in this. Please recall the other options. If you are able to, please help me out to reach up to the other options as well. Okay. So absolute contraindication, we have discussed. What is the absolute maternal contraindication? So if the mother is actually undergoing any chemotherapy or radiotherapy, that is the only single maternal absolute contraindication. Okay, so maternal chemo or radiotherapy is an absolute contraindication from the mother's side. It is an absolute contraindication from the mother's side. और बच्चे की तरफ से, if the child is not able to digest the milk, right? If the child is not able to digest the milk itself, so that means the child, if he is having galactosemia or if the child is having lactose intolerance. Okay, so these are the two absolute contraindications for breastfeeding from the child's side. Okay, so galactosemia, lactose intolerance. In lactose intolerance, the child is having deficiency of lactase enzyme, right? Whereas in galactosemia, the child has a deficiency of galput enzyme. Okay, gal1 put, that is galactose 1-phosphate uridyl transferase enzyme, or in minor cases the child has deficiency of galactokinase. But if there was deficiency of galactokinase, then the child has very milder manifestations of the disease. Okay, the classical galactosemia only manifests if there is galput deficiency, right? So galactosemia is definitely an absolute contraindication of breastfeeding. What were the other options? Anybody able to remember? Herpes था option में, HIV था option में, anything like that? If you are able to recall, please just let me know. Is there a lag or what? Is there any lag as such? No other options? Okay then. चलो moving further, ठीक है. Question number 18, a repeat question of FMG itself, okay, repeated in NEET PG as well earlier, but this was a recent repeat here, FMG ka, so I hope so none of you has marked it wrong. Necrolytic migratory erythema, okay, necrolytic migratory erythema is seen in which of the following conditions? Okay, so this is the image which came earlier. अभी image नहीं आई थी शायद. Okay, you are sure about the answer, तो टेंशन ही नहीं है. Galactosemia was the answers. कोई दिक्कत नहीं है if you are not able to recall the other options. So here, okay, here please remember this is a case of necrolytic migratory erythema, as you can see over here. Okay, so here the patient usually gets erythematous and necrotic patches, okay, which will shift on location. Okay, so if the patient is having those patches, for example sometime in leg, after few days the patient will get them on thigh, okay, and like that they keep on progressing and they keep on migrating from one side to the other. So this is a case of necrolytic migratory erythema, and it was a classical feature of that. Was a different question. Pellagra ko alag question tha. This was necrolytic migratory erythema, I feel. So here the answer was glucagonoma. Okay, please remember necrolytic migratory erythema is commonly associated with glucagonoma. Please remember that was a straightforward answer. ठीक है, जो तुम बोल रहे हो that will discuss. I hope so that is there in the questions too. ठीक है, this was the perimetry that was given, right? Identify the site of lesion, they ask you from the below given perimetry image. So there were two questions from neuro-ophthalmology. अगर तुमने वो neuro-ophtha का अपन ने जो चार्ट बनाया था वो भी पढ़ लिया होता, I hope you would have been able to mark these two answers correctly. तो जल्दी से बता दो. I hope this was the perimetry image which was given in the question, because this was the recall from most of the students. Identify the site of lesion from the below given perimetry image. So here the perimetry image shows what? You can see there is loss of vision. ये जो blackening दिख रही है ना, that is what is loss of vision, right? So there is loss of vision, okay, in temporal fields of both the eyes. Okay, there is loss of vision in temporal halves of both the eyes. Okay, and therefore this condition is what is called as bitemporal hemianopia. Okay, half of the vision is lost, so therefore it is called as hemianopia. And which fields are gone? The temporal fields are gone in both the eyes, therefore it is called as bitemporal hemianopia. Right, that was very clear. No issues with that, anybody now? So this is a case of bitemporal hemianopia, and we know एक side पे left sided vision loss है, दूसरी side पे right sided vision loss है. So the sides are not the same, and therefore this can also be called as heteronymous hemianopia. This can also be called as heteronymous hemianopia. If the sides are same, okay, in both the eyes, then it is called as homonymous hemianopia. So this is a definitely case of heteronymous hemianopia, also called as bitemporal hemianopia, and it is due to compression of, we know. Now if the temporal vision fields are lost, matlab which fibers are gone, which fibers are compressed? In eye there is a cross innervation, we know, right? So the temporal fibers are responsible for nasal vision, and the nasal fibers are responsible for temporal vision. That is clear. So if the temporal visions are lost, which fibers are compressed? The nasal fibers are compressed, and we know usually the nasal fibers, both of them, they cross at the level of optic chiasma. They cross at the level of the optic chiasma. Okay, तो कुछ लोग बोल रहे हैं there was peripheral optic chiasma and central optic chiasma in the option. So we have discussed definitely in the peripheral optic chiasma the temporal fibers go their way. Okay, in the central optic chiasma definitely there are nasal fibers which will cross or decussate, and therefore in the central optic chiasma if it is compressed, then there would be compression of the nasal fibers, and agar nasal fibers compress hote hai, then in both the eyes the temporal vision fields are gone, right? So that is what is important. So please remember, if the optic chiasma is compressed, patient develops bitemporal hemianopia. We have discussed the causes as well. It can be due to, most commonly it is due to a pituitary adenoma. Most common pituitary adenoma is usually a prolactinoma which causes this compression. It can also be seen in a child with a calcified brain tumor called as a craniopharyngioma. It can also be seen due to anterior communicating artery aneurysms as well, right? तो ये सब causes भी हमने discuss किए थे. No issues with this, anybody? That's important. And there was another question which was given. There was no perimetry image. I think a lot of people are saying कि perimetry image एक ही question में थी. Okay? So the next question which was framed, it was something like this. A person comes to the ophthalmology OPD or to the OPD with complaints of vision loss. in right halves of both the eyes with macula sparing. What is the site of lesion? Was this the question, or did they ask what is the type of vision loss? Like hemianopia का type बताना था तुम्हें. Acha, 4Ds of glucagonoma were mentioned in the question, Hanan. Okay, great. Then the diagnosis was much easier for all of you. So, I hope this was the question. हाँ ना तो बोलो. So I hope this was the question. Okay. So there was no perimetry image. It was only described in the question itself in a statement format. So there is vision loss in right half of the both the eyes. If I draw the perimetry, it would appear something like this. Okay. So there is vision loss in right half of both the eyes. ठीक है, vision loss in right half of both the eyes. And if same sided vision losses है, दोनों आंखों में कौन सी साइड की विजन गई है? राइट हाफ राइट साइड की विजन गई है. ठीक है. So definitely this is a case of homonymous hemianopia. This is a case of homonymous hemianopia. That's easy. Okay. Why? Because same sided vision loss is there in both the eyes. Therefore it is a case of homonymous hemianopia. And we discussed homonymous hemianopia अगर होता है, it is always, the site of lesion is always and always contralateral. मतलब if there is a right sided vision loss, there would be a left sided lesion. Okay, if there is a left sided vision loss, there would be a right sided vision. That was pretty clear कि the site of lesion is always contralateral. ठीक है, एक important बात. और दूसरा important फंडा मैंने क्या बोला था? If, okay, please remember, homonymous hemianopia, it is always due to any region below the optic chiasma. It is due to any region below the optic chiasma. So for example, if the optic tract, if the optic tract is compressed, or the lateral geniculate body, or the optic radiations, or the visual cortex. So any lesion or any compression in these areas will lead to a homonymous hemianopia. But if they have discussed about macula sparing also, that means there is no vision loss in the field of macula. There is no vision loss in the field of macula. Macula is absolutely normal. अगर macula sparing mention किया गया था, if macula sparing was mentioned in the option, then definitely the site of lesion would be the visual cortex. The site of lesion is the visual cortex that we have discussed already in the class as well. ठीक है? Site of lesion is visual cortex. And हमने बोला है कि below optic chiasma, the site of lesion is always and always contralateral. So if there was a right-sided vision loss, which visual cortex should have been affected? The left visual cortex should have been affected. So answer would be option B, left visual cortex. कोई दिक्कत नहीं है इसमें? Left visual cortex should be your answer. चलो, I hope this was easier for all of you. Moving further, question number 21. Again a confusing question. कुछ लोग ये बोल रहे हैं, कुछ लोग वो बोल रहे हैं. So I hope ENT at least गलती नहीं करी है इसमें यार. This was a very easy question for all of you. So question starts. A teacher complains of hoarseness of voice. Okay, on examination I'm not sure, therefore I have included both of them, whether they have mentioned a bilateral or a unilateral mass. Okay, which is observed at the junction of anterior 1/3 and posterior 2/3 of the vocal cord, because they have said it was classically mentioned, the site was classically mentioned. ठीक है? What is the likely diagnosis now? And please remember, लोगों ने ये कहा, see, please remember, I have not told, I have discussed this in class a multiple number of times. It is not black actually, it is appearing to be black. Okay, OBS use कर रहे हैं ना, so therefore it is appearing to be black. I'll use yellow. Okay, so anything green or in that shade will appear black. Actually, that's the problem. Okay, so a teacher complains of hoarseness of voice. So these were the two things, and the site again. With these three things, they decided that it was vocal nodules only. With these three highlighted things, they decided it was vocal nodules only. मैंने क्लास में चीख के कहा था हर बार. Okay, whenever I was conducting the classes or even the test and discussion sessions, these are the common complaints for anything. Okay, most common cause क्या है दोनों की? Most common cause for vocal nodules or vocal polyp is same, that is vocal abuse. Okay, when you scream a lot. Okay, and most common site क्या है दोनों की? Most common site is also the same. It is junction of the anterior 1/3. It is junction of the anterior 1/3 and posterior 2/3 of the vocal cord. And why it is the most common site? Because we know it is the most vibrating part of the vocal cord, right? So this junction of anterior 1/3 and posterior 2/3 of the vocal cord, this is the most vibrating part, and therefore it is the most common site affected with vocal nodules or vocal polyp. Okay, so site is also same. The most common complaint, hoarseness of voice, is also same. Teacher, vocal abuse is the cause, so teacher can get both vocal nodule as well as vocal polyp. Important is you had to differentiate with the help of this one. I mentioned ke kaha hai hamesha, whether it was unilateral or bilateral, or second thing, whether it was less than 3 mm or more than 3 mm. Chalo, if the size was not mentioned, they definitely mentioned something, whether it was a bilateral mass or a unilateral mass. So we know, please remember, vocal nodules are always and always bilateral in nature, right? Vocal nodules are always and always bilateral in nature. As you can see, these are pea-sized nodules, less than 3 mm in size, and they are bilateral always. No issues with this. Whereas polyp is generally more than 3 mm. Ho sakta hai kam, but it is generally more than 3 mm. It is nothing but a pedunculated mucosa, more than 3 mm in size. Okay, and it is mostly unilateral. It is mostly unilateral. So what was mentioned? Jaldi se clear karo. Unilateral or bilateral? So Lakshman is saying bilateral. So if bilateral was definitely mentioned, then your answer is straight away vocal nodules. Okay. So if bilateral is mentioned, answer is straight away vocal nodules. But if unilateral was mentioned, then the answer would be vocal polyp. Vocal nodules के लिए treatment भी हमें पता है. We will actually give speech therapy to the patient along with voice rest. Okay. So voice rest along with speech therapy is recommended. Whereas for vocal polyp, we will go for a MLS, microlaryngeal surgery. That is a CO2 laser excision has to be done. Okay. Whereas these two other ones, keratosis, larynx and Rinke's edema, can be caused by vocal abuse, but the more commoner cause for both of them is smoking. For both of them it is smoking. In keratosis larynx, there is faster shedding of the vocal cord epithelium, and in Rinke's edema, there is actually accumulation of fluid, or there is edema of this Rinke space. What is the Rinke space? It is the subepithelial space. As you can see, these are the true vocal cords. Okay, and just beneath the epithelium you can see there is accumulation of fluid. This is what is called as Rinke's edema. Okay, the treatment for keratosis larynx and Rinke's edema is same, and that is nothing but stripping of the vocal cord mucosa, and that is what is called as decortication. That is what is known as decortication. Okay, I hope this was clear with everybody now. Okay, so no issues till here. Question number 22, moving further. Which among the following tests is not used for blood stains? Okay, which among the following tests is not used for blood stains? Important question from forensic, because I had definitely covered it multiple times. Even in QRS में भी तो मैं cover करवाया था ये again. So I hope all of you are quite aware. Takayama, Teekmans, precipitating. All of these are tests used for blood stains. Okay, these are tests used generally for blood stains. And the third one, now the fourth one, it is a benzidine test. Okay, the fourth one, please remember, it is a benzidine test which is generally used. Okay, benzidine test. No issues with this. So please remember, these are the tests generally used for blood stains. But which is an exception over here? We know Barberio's test is a test used for seminal stains. Okay, Barberio's test is a test used for seminal stains. That is important. Okay, Barberio's and Florence are the two tests which are generally used for seminal stains. So this is an exception. It is an odd man out. Okay, so that was a straightforward question. Nothing to be much discussed about it. Okay. Question number 23 now. Here it says a 16-year-old boy. Very easy question from ENT. Again, no mistake should have been done. There were two questions from this Sarkari topic, and the topic was juvenile nasopharyngeal angiofibroma. Easy one. And there were two important questions. No question asked about the diagnosis, but one question asked about the investigation or the best investigation, and the second question asked about the treatment, right? So here one of the questions was a 16-year-old boy comes to the OPD with complaints of recurrent profuse epistaxis. Okay, so here it is a 16-year-old boy. That means a teenage boy or an adolescent boy, who is also called as a juvenile age group. Okay, so a juvenile boy who comes to you with recurrent profuse epistaxis without a known cause. तुम्हें पता नहीं है cause क्या है, but there is a recurrent profuse epistaxis which occurs in the patient. Okay, along and now they are asking what is the best step for assessment of this condition. What is the best step for assessment? So I hope all of you are quite aware. Juvenile nasopharyngeal angiofibroma, it is a highly vascular tumor which arises from the spinopalatine foramen. Okay, it arises from the spinopalatine foramen, and it usually grows. Okay, it usually grows in the nasopharynx, and then it can spread into the pterygomaxillary fissure. It can spread into the pterygomaxillary fissure. It can spread into the orbit, and therefore it can cause proptosis or frog face deformity as well. So all of these features were there. ठीक है, तो ये clinical presentation हुआ. And as it is a vascular tumor, okay, so the new blood vessels will keep on forming, and these new blood vessels which are usually formed, these are very fragile and they easily rupture and cause profuse epistaxis in the patient. ठीक है, तो ये classical case था. So what is the best step? One was treatment, people said me. One was this investigation, they said. So if they are asked about investigation, then definitely we know, as it is a highly vascular tumor, biopsy is absolutely contraindicated. ये हमें पता है. This we have written in our notes too. Okay, so biopsy is absolutely contraindicated. Whereas if FNSC में भी तुम needle use करोगे ना यार. FNSC also you will use a needle. So definitely FNSC is also contraindicated. Please remember, FNSC would also be contraindicated because that can also cause bleeding in the patient. Okay, and as we know, whenever we need to actually go for identifying a vascular tumor, we will try to go for a contrast study. Okay, because we need to identify the site of origin of the tumor itself. Okay, so therefore CECT, a contrast enhanced CT scan, would be the preferred investigation or the best step for assessment or investigation. Okay, and on CECT we can see a anterior bowing of the maxillary sinus wall, and this is what is called as which sign? It is what is called as your Hallman-Miller sign. I am coming to the treatment also, don't worry. Okay, this is what is called as your Hallman-Miller sign, also known as your antral sign, right? Now if they asked you about the treatment, okay, if they ask you about the treatment, one of the options I feel that was chemotherapy, right? The other options was radiotherapy. The third option was surgical excision, and the fourth option, anybody, if you are able to recall it, the fourth option was. So here we have discussed this also again in great details a number of times again in the classes in T&Ds. Here यहाँ पे हमेशा याद रखना, if it is a juvenile nasopharyngeal angiofibroma, okay, definitely we need to go for a surgical excision. We need to excise the tumor because it is locally invasive. Okay, so please remember, as it is invasive in nature, we need to surgically excise the tumor. That's important. Okay, and to prevent the bleeding, तुम बोलोगे यार तुम needle के लिए मना कर रहे थे biopsy और FNSC के लिए, you are going to surgically excise it. Yes, but before surgical excision we will go for a preoperative embolization. We will go for a preoperative embolization. ये भी मैंने बोला था, to decrease the chances of bleeding in the tumor, right? We will go for preoperative embolization followed by surgical excision. No issues with this, anybody? So that was the other question that was asked about juvenile nasopharyngeal angiofibroma. कोई दिक्कत नहीं है इसमें? I hope this was very clear. Question number 24. Identify the diagnosis from the given image. Now I was not able to get, some people are saying that a CT image was definitely given or MRI image was definitely given. Sorry. Okay, a CT or MRI image was definitely given, and the second, some people are saying that a X-ray or a IVP image was given. So this one definitely is a IVP image, क्योंकि मैंने हमेशा बताया तुम्हें differentiate कैसे करना है. If you can see dye in the bladder, definitely that is a case of IVP, intravenous pylography. Okay, here you can see there is dye in the ureter, dye in the bladder as well. So this is a case of IVP. And here on IVP, which sign would be seen? What is the sign that we see on IVP or on a CT scan? On a CT scan that or MRI, you can usually see a U sign. Okay, you can see a U sign. But on the other, okay, please remember on IVP, okay, on an IVP you can see that hand joining sign. You can get that hand joining sign or the flower vase appearance. You can get that hand joining sign or the flower vase appearance. No issues with this. Hand joining, hand shaking, flower vase appearance, it is one and the same thing. That would be seen on a IVP or a IVU, whatever you call it. ठीक है, तो अगर ये image थी या फिर ये image थी, no issues with this. Whatever it was, here you can see these are the ectopic kidneys. Kidneys are not present at their original site, rather they are present towards the midline, and the lower poles of this kidney are fused together at the midline at the level of, ये question था, they are fused at the level of L4. Vertebral level of fusion was asked. Previous question है, ये याद रखना. ठीक है, so they were fused at the level of L4 usually, and it presents with the abdominal mass. So this is definitely a case of horseshoe kidney. Please remember, it is a classical case of horseshoe kidney. There is a pair of ectopic kidneys. Okay, there is a pair of ectopic kidneys, and these ectopic kidneys, उनके जो lower poles होता है, these lower poles usually fuse in the midline. कोई दिक्कत नहीं है इसमें. Important. Please remember this. ठीक है, चलो. We have discussed investigation of choice is usually a CECT that we do, and if the patient is symptomatic or if the patient is having pressure symptoms, then we will go for a surgical resection. Otherwise we will not go for surgical resection. ठीक है, कोई दिक्कत नहीं है, please remember. ठीक है, polycystic kidney disease में IVP we discussed, the IVP QRS में discuss कराया था मैंने. IVP in a polycystic kidney disease usually gives us which appearance? It gives us a spider leg appearance. Okay, it gives us a spider leg appearance. No issues with this. Chalo, moving further. Question number 25. A patient complains of silvery scales over the scalp and extensors. There is pitting of nails also with hyperkeratosis of the nails. What is the most probable diagnosis? What do you think? Was this the question, the exact language or similar kind? Silvery scales to tha. A lot of people have given me that they definitely mentioned silvery scales in the question. They were over the scalp and the extensors. There was pitting of nails also, and there was hyperkeratosis of the nails. What is the most probable diagnosis? So we know if there are silvery mica-like scales, okay, silvery mica-like scales, usually on the extensors or on the scalp, definitely the diagnosis is psoriasis. Definitely the diagnosis is straight away psoriasis. Please remember this, okay? And what are the three important nail findings of psoriasis? They are remembered by the mnemonic PSO, as we have always discussed. P goes for pitting of nails, okay, which is a important and a common finding. The most common finding of nails in psoriasis is pitting of nails, which are also called as thimble nails, right? They are also called as thimble nails. S goes for a subungual hyperkeratosis. S goes for subungual hyperkeratosis, and O goes for the most characteristic nail sign, which was a recent NEET PG question, that is the oil drop sign. Okay, oil drop sign. And O can also stand for onycholysis, that is destruction of your nails. Okay, so these are the three important nail findings. So if these were the two things that were mentioned, silvery scales along with pitting of nails, then definitely the diagnosis is psoriasis. कोई दिक्कत नहीं है इसमें. I hope I have made myself pretty clear. Moving further now. Question number 26. Death of a person took place during police investigation. Inquest will be done by whom? Okay, which authority? So this was again a forensic question, repeat question. Okay, and so Vikas sir has discussed that in details now. I don't need to discuss it much more. So death of a person which took place during police investigation, okay, or in the police custody. Okay, so death in the police custody is definitely inquired or investigated, or the inquest is carried out by whom? It is not carried out by the police, because the police are held responsible for the crime, right? So definitely the police will not be given the authority to conduct an inquest. Okay, neither the High Court or Supreme Court. Okay, the trials are usually run in the High Court and Supreme Courts. Inquest is not carried out by the High Court or Supreme Court. Okay, so it is the magistrate who carries out the inquest. Please remember, it is the magistrate. Okay, in cases of dowry death, please remember, in cases of dowry death, in cases of custodial death, okay, in cases of custodial death, in cases of exhumation, important चीजें बता रहा हूँ बस. In cases of exhumation, the inquest is generally carried out by the magistrate. Okay, exhumation is digging out of dead bodies. Okay, so in all these conditions, the inquest is carried out by the magistrate. Magistrate inquest is covered under CRPC 176, higher number, so higher authority, that is CRPC 176, and police inquest is covered under CRPC 174. Okay, police inquest under CRPC 174. Okay. Question number 27 now. A pregnant lady was brought to the labor room with ongoing labor. Okay, please tell me if it was ongoing labor, first thing. Second, trial of labor can be given in which condition? And the options were classical cesarean section, previous cesarean section. What were the other options, anybody, if you are able to recall? Because I know obs-gynae questions were a bit tricky this time, but it's important to recall the other options also, because then we'll be able to get the best answer from it. ठीक है, तो जल्दी से बाकी के दो ऑप्शंस रिकॉल कर दो यार. It would be easier for me to give you an answer then. So if these were the two options, definitely we know classical cesarean section में, okay, classical cesarean section में we will never go for a trial of labor. We will never go for a trial of labor. That we are very sure about. ठीक है, just a minute. Why? Because the risk of rupture is almost around 20%. Okay. In classical cesarean section, what is the difference between a classical and a lower segment cesarean section? In classical cesarean section, usually the incision is usually given on the upper segment, but in LSCS the incision is given on the lower segment. Okay, it is given on the lower segment. Okay, so please remember, this is important, that if it was a previous case of classical cesarean section and if you try to give a trial of labor in the subsequent delivery, then there would be a risk of rupture. Okay, there would be a risk of rupture which is almost around 20%, whereas the risk of rupture in a LSCS case is only around 0.2%. No issues with this, anybody? That's important. Why? Because the lower segment is relaxed. Okay, during ongoing labor or contractions, the lower segment is relaxed, and therefore there would not be a high risk of rupture in cases of a lower segment cesarean section. So if the patient have had only one lower segment cesarean section, then only a trial of labor can be given. Even if the patient has had two lower segment cesarean section, then trial of labor cannot be given. Okay, then the trial of labor cannot be given. Only one LSCS हिस्ट्री अगर है, then definitely we can go for a trial of labor. Okay, no issues with this. So अगर ये दो options थे, इसके अलावा मुझे options बता दो if you are able to recall it properly. If you are not able to recall, then a previous cesarean section or a previous LSCS, whatever was mentioned, would have been the best answer. Okay, because classical में तो absolutely we did not go for any trial of labor. This is a repeat question from NEET PG. Okay, which has been commonly repeated nowadays. ठीक है, तो ये डिस्कस भी कर चुका हूँ मैं आपके साथ. ठीक है, चलो then moving further. Question number 28. Please give the other options. अगर याद आ रहे हो तो please add it up. Okay, keep on adding the other options. It is an interactive session. I want your opinions to in the. Question number 28. A 6-year-old child with short stature has bone age of 6 years itself, and his height corresponds to the mid-parental height. Which is the most common cause of this? So this was the question now, because certain people are saying definitely like there was a different framing which was done at various platforms. So here I feel this was the closest that I could get to the question, that a 6-year-old child was given and his born age was also 6 years itself. That means the chronological age is equal to the born age of the child. Okay, the chronological age is equal to the born age of the child. And second, they mentioned that his height, the height of the child, okay, the height of the child is corresponding to the mid-parental height. Okay, so that is important. So which is the most common cause of this? So I hope all of you are quite aware that the born age, if it is less than the chronological age, if the born age is less than the chronological age, then the diagnosis would have been CDGP, that is constitutional delay in growth and puberty, and growth hormone deficiency. Both of these, CDGP as well as growth hormone deficiency, both of these will lead to a born age less than the chronological age. But in our question, the chronological age is almost equal to the born age. So here, please remember, the diagnosis should be familial short stature. What are the basic differences between CDGP and familial short stature? We know in with both these conditions, definitely the child is having a short stature. But the final height, if I talk about, okay, in a case of CDGP, the final height of this patient would be absolutely normal. Okay, now he is having short stature, but the final height which he will attain in adulthood would be absolutely normal. But in familial short stature, it will remain low only. Okay, the final height attained would remain low only. Okay, but it is normal according to the familial standards. If I talk about the parent's height, if I talk about the family history, okay, if I talk about the family history, here the parents usually have a normal height. Here the parents also usually have a normal height, but here the parents usually have, please remember, here the parents usually have a short stature. Here the parents usually have a short stature. Most important, here the parents can complain of history of delayed puberty. Here the patients can definitely, here the parents can complain of delayed puberty. मतलब माँ में भी या पापा में भी delayed puberty हो रखी थी पहले. Okay, so that can be a case of CDGP. But here there would not be any such history of delayed puberty in the parents. Okay, there would not be any such history of delayed puberty in the parents. Please remember. Okay, so that's important. No issues with this, anybody? So these are the important things that you need to remember. Okay, so if born age was given less than the chronological age, then there could have been both answers, CDGP as well as growth hormone deficiency. But now here, as it is equal to the chronological age, answer is familial short stature. ठीक है, चलो. And we know achondroplasia में, please remember, there is a short limb dwarfism. Okay, it is a disproportionate short stature, and where the limbs are only short, the rest of the trunk and the body is absolutely normal. ठीक है, that is what is the case of achondroplasia. Question number 29, if I ask you, it says which of the following drugs at the site marked as C. शायद question में X mark किया गया था. That is one and the same thing. And nephron was placed something like this. ठीक है. So for example, this was your Bowman's capsule, this was your PCT, this was your loop of Henle, ठीक है, and this was your DCT. And at the first elevation itself, it was marked. ठीक है. So it was almost at the junction, but definitely it was very clear that they are marking the DCT itself. They are marking the distal convoluted tubule itself. Yeah, it would be on YouTube most probably. Okay. So please remember the site which was marked was X, and it was marked on the DCT. Okay, the first site of DCT, distal convoluted tubule. And I hope we have discussed it in great details. Pharma chanting में भी है तुम्हारे. In class also we have discussed all of it. ठीक है, तो sir ने भी discuss किया है definitely. So here I hope all of you are quite aware. Okay, all of you are quite aware of this. Definitely, if they would have marked over here, that is at the level of loop of Henle. At the level of loop of Henle, we have which transporters? We have sodium potassium 2 chloride transporters. Okay, sodium potassium 2 chloride transporter. And if the drugs will inhibit this sodium potassium 2 chloride transporter, then these are called as loop diuretics. These drugs are loop diuretics. Whereas if the drugs are acting at this site where we have usually sodium chloride co-transporter. Okay, we have sodium chloride co-transporter at the level of DCT. And the drugs which will inhibit the sodium chloride co-transporter are none other than thiazides. Okay, these are drugs known as thiazides. And the option which was given was definitely option A. Hydrochlorothiazide was there in the options, right? So please remember, hydrochlorothiazide will inhibit the sodium chloride co-transporter, which is present at the level of DCT, which has been marked in the question that was given to you. कोई दिक्कत नहीं है इसमें? No issues with this, anybody? Okay, and we know the other drugs. Okay, at the level of collecting duct, if they ask you, at the level of collecting duct, the potassium sparing diuretics usually act at the level of collecting duct. Okay, the potassium sparing diuretics, something like the aldosterone antagonist, or the drugs like the aldosterone antagonist, sorry, or sorry. ठीक है, तो either aldosterone antagonist or ENaC blockers usually. Okay, the paste is the demonic that we have discussed multiple number of times. So तो aldosterone antagonist, something like spironolactone or eplerenone, or ENaC blockers. Okay, drugs like triamterene or amiloride. Okay, all of these, they will act at the level of the collecting duct. No issues with this. And if they mark at the PCT, at the proximal convoluted tubules, then definitely I hope all of you are quite aware that the carbonic anhydrase inhibitors, drugs like acetazolamide, they usually act at the level of the PCT, proximal convoluted tubule. कोई दिक्कत नहीं है. So these was all about your diuretics. So here the answer is definitely hydrochlorothiazide. ठीक है. Moving further. Question number 30 now. Yes, definitely the diagram. This image was something different. Okay, in the question number 30. But more important, I want the answer from you. Name the drug which acts at the marked site. So if I mark the site over here, okay, the site was over here, right? So I hope it was something like there were JG cells, okay, and these JG cells will secrete renin, okay. These JG cells are definitely secrete renin, they are secreting renin, and this renin is then actually converting angiotensinogen to angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 by the ACE enzyme, that is angiotensin converting enzyme, and further this angiotensin 2 is responsible for production of aldosterone, and it has its individual actions too. Okay? So this was the RAS system, that is your renin angiotensin aldosterone system. Okay, this was the RAS system, okay, which is usually activated in response to low blood pressure or hypotension. Okay? So now here they marked it. Am I clear? Are you pretty sure that it was marked between angiotensin 1 and angiotensin 2? Just let me know that. Are you pretty sure that it was marked between angiotensin 1 and angiotensin 2? Because otherwise the answer will change. Okay. So if it was marked before the renin release, we know the drugs which will inhibit the renin release, these are none other than beta blockers, okay, because JG cells have beta 1 receptors, okay, and whenever these beta 1 receptors are stimulated, then there would be secretion of renin. So if we give beta blockers to the patient, definitely the JG cells will not be stimulated, and therefore there would not be any secretion of renin which will occur. So if they ask you indirect renin inhibitors, if they ask you renin release inhibitors, then the answer should be beta blockers. This was a previous year question, yaad rakho ye. Renin release inhibitors are beta blockers. But once the renin is secreted and it converts angiotensinogen to angiotensin 1, okay, if they ask you which is the drug which will act over here, okay, which will inhibit the renin, so the drugs which directly inhibit renin are called as direct renin inhibitors, okay, the drugs which will directly inhibit the renin action are called as direct renin inhibitors, and these are usually the Kiran drugs, Alice Kiran, Ramikiran, okay. So please remember these Kiran drugs, they are called as direct renin inhibitors, okay. Whereas if the arrow was marked between angiotensin 1 and 2, where the angiotensin converting enzyme usually acts on, and here if it was the arrow, so the drugs which will inhibit the angiotensin converting enzyme, these drugs are generally called as ACE inhibitors. These are called as ACE inhibitors, and these drugs are called as Pril drugs, right? These are what are your Pril drugs: Captopril, Lisinopril, Enalapril, Ramipril. All of these Pril drugs, they usually act at this level, okay. So please remember the arrow where it was. It is important to remember that one, okay. So agar most of the people are saying the arrow was this one, the arrow was here somewhere, I'll just highlight it with the color, okay. So they are saying this was the arrow. So if this was the arrow, the one marked in yellow, definitely the answer should be ACE inhibitors which will act at this level, and the ACE inhibitors which will act are called as Pril drugs, that is Ramipril would have been your answer. But agar tum bolte ho ki it was before angiotensin 1, then your answer should be Alice Kiran, okay, then your answer should be Alice Kiran, okay. No issues with this anybody now, okay. Please remember. Chalo aage badhte hain, okay. Losartan, I hope all of you are quite aware, it is an angiotensin receptor blocker. Once angiotensin 2 is released, then it will bind to the angiotensin receptors. So here, over here, okay, to block the action of angiotensin 2, then definitely ARBs are generally used. Question number 31. What is the mechanism of action of labetalol? This was a pretty straightforward question. QRS mein bhi repeat karwaya tha, okay, and I hope none of you have made a mistake in this now. Labetalol, we know it is a drug which is nowadays used for hypertension in pregnancy, okay. So it is the drug of choice for hypertension in pregnancy when it is given orally, and it is also the drug of choice for hypertensive emergency in pregnancy when it is given via IV route, right. So it is the drug of choice for both the conditions. And labetalol, okay, it is one of the adrenergic antagonist drugs which will block both the adrenergic receptors, that is alpha as well as beta adrenergic receptors. The other drug which has the same action is carvedilol, right. I hope so. Labetalol and carvedilol has same action. Both of them can block both the adrenergic receptors, that is alpha as well as beta adrenergic receptors, okay. So please remember. Option A says it acts as directly acting arterial vasodilator resulting in indirect tachycardia. No, okay. Option B says it primarily acts as a vasodilator with little effect on arterioles. No, this is also not true. Sorry. It decreases peripheral vascular resistance by directly relaxing the vascular smooth muscles, okay. So please remember, it does relax the smooth muscles, but it is not the only action. So option D is the most important, like the closest statement for the mechanism of action of labetalol. Here it says it causes blockage of both the alpha as well as the beta adrenergic receptors. So that is the closest answer that you could get, okay. So please remember, here the answer should be D, blockage of both alpha as well as beta adrenergic receptors. That was a straightforward question again. No issues with this. Question number 32. यहाँ पे graph बना देता हूँ मैं, what I have got from the students, okay. So this was the response and on y-axis, and this was the log dose on x-axis, ठीक है. So here there were few drugs. First one was A, the second one which was marked. Okay, the other two that were marked were B and C, almost at the same height, and then the last one which was marked was D usually, right? So this was something like this. Okay, it was something like this. Now please tell me the answer. What do you feel? So now this is a log dose response curve, we know, and log DRC are usually sigmoidal in shape. We have discussed that. And usually if I talk about a log DRC, there are three important parameters that you usually assess with the help of a log DRC. What are these three important parameters? First one is the efficacy of a drug that you can assess. Second is the potency of the drug that you can assess. And third is the safety of the drug. Okay. And what are the parameters to assess them? Sorry. So efficacy is usually assessed with the height of the graph. If height of the graph is more, that means the drug is more efficacious. That is important. Then potency is assessed with the side of the graph. Matlab, if the graph is towards the left side, that means the drug is more potent. Okay. So please remember that graph which is on the extreme left, that means the drug is the most potent drug out of all. Okay. Yaad rakhna. So left side determines the potency of the drug. Okay, or power of the drug. And safety is determined by the slope of the graph. Okay, so if the slope is flatter, that means the drug is safer. But if the slope is steeper, something like this, then you know the drug is unsafe. Then the drug is unsafe. No issues with this, anybody? That's important. Okay. So now option A says drug C is less potent than drug B. Okay, drug C is less potent than drug B. क्या दिख रहा है यहाँ पे? The drug C and drug B, जो exactly image आई थी exam में, both of them were of equal height, right? Both of them were of equal height. Okay, so both of them were equally efficacious. But if I talk about the potency, we know potency is determined by the side of the graph. Okay, potency is determined by the side of the graph. So here you can see drug C is definitely on the right side and drug B on the left side. So definitely drug B is more potent. Okay, so here it says drug C is less potent than drug B. That's a true statement, right? That's a true statement. Then drug B is more efficacious than drug B is more efficacious than drug D. Yes, the height of drug B is more than the drug D graph, and therefore definitely this statement also stands true that drug B is more efficacious as compared to the drug D. Drug D is least potent. Yes, because it is on the extreme right. मैंने क्या बोला? Left side में जो graph होगा वो ज़्यादा potent होगा, जो right side में होगा वो सबसे कम potent होगा. So drug D is on the extreme right and therefore it is the least potent drug. That's also a true statement. Drug A is most efficacious. Efficacy is determined by the height. Rather, drug A does not have the maximum height, and therefore this is a wrong statement or a false statement that you need to identify, that drug A is not the most efficacious drug. It is not the most efficacious drug. Okay? So answer would be option D over here. Question number 33. What are the types of twins if division usually occurs between 9 to 12 days? ये भी QRS में last में वापस से discuss किया था हम लोगों ने. Okay, so the type of monozygotic twins usually when one ova is fertilized by a single sperm usually and a single zygote is formed. Then that single zygote usually divides and then it forms the twins. Okay, such type of twins are definitely called as monozygotic twins. And if I talk about the monozygotic twins, it depends on the time of division. Okay, which kind of twins they would be. If the division occurs within 3 days, then the twins which would be formed are DCDA twins, that is dichorionic diamniotic twins with separate membranes and separate placenta. Okay, if the division occurs usually within 3 to 8 days, then definitely please remember it would be MCDA twins, that is monochorionic diamniotic twins. They will share the placenta but not the membranes. Then third, if the division occurs between 9 to 12 days, which was asked in the question as well. If the division occurs between 9 to 12 days, then definitely the type of twins would be Momo twins, what we call them. Okay, but it is called as MCMA twins, that is monochorionic monoamniotic twins. They will share the placenta as well as their membranes. Okay, and lastly, if the division occurs, please remember, if the division occurs after 12 days, then definitely the twins which are formed are called as conjoined twins, also called as Siamese twins. These would be also called as Siamese twins. Okay, yaad rakho. So here if they ask you the division occurs within 9 to 12 days, the type of twins would be MCMA or monochorionic monoamniotic. So यहाँ पे mono होना चाहिए था, ठीक है? So it should be monochorionic monoamniotic twins. No issues with this, anybody? I hope this is pretty clear with everyone. Monochorionic, monoamniotic. Question number 34 now. A factory worker, यहाँ पे थोड़ा statement में, last statement में there is some trick over here. Let's get to that. Okay, a factory worker lives in a factory provided quarters with his wife and a 3-year-old baby. His brother and his wife, okay, his brother and his wife comes to him every winter vacation for 1 month. Okay, definitely they are coming to him for a small period of time. A surveyor visits their house. He will mark the family as. So please remember what was the exact line, the last line, that's important, because depending on that the answer will change. Okay, usually if they ask you what kind of a family it is, so definitely agar tum bologe which kind of a family it is, when only one couple lives with their own children, one couple with children, if they live together in a house, this is what is called as a nuclear family, right? This type of a family is what is known as a nuclear family. But please remember, if there are other people also apart from that couple and their children, if there are other people also, then that type of a family would be called as an extended family. Here, if they ask you which type of a family it is, if that was a direct statement, then the answer can be nuclear family. But यहाँ पे उन्होंने एक statement add करा था that a surveyor comes to visit their house, and now during the research or during the survey, he will mark the family as. So here now, please remember, the surveyor, what is it getting? He is actually looking the family from outside, and he is getting to know that it is a family with almost 2 couples and their children. So he will mark the family as an extended family. Okay, अगर वो उसके नजरिए से देखा जाए, okay, from his point of view, from his perspective, definitely it would be an extended family. But if they ask you what kind of a family it is, if that was a direct question, then your answer should be nuclear family. ठीक है? So please remember guys, depending on the statement, the answer will change. Depending on the statement, the answer will change. ठीक है? That's important. No issues with this, anybody? याद रख लेगा. Question number 35. That was a straightforward question. Identify the disease from the given image. A previous year question, commonly repeated, and a very easy spot diagnosis. क्या था ये? In a particular dermatomal segment, you can see there are some painful vesicles. Painful तो नहीं बोले थे उन्होंने. They have just given some fluid-filled vesicles or blisters that were seen. ठीक है? So red painful vesicles usually in a particular segment or a dermatome. Okay? Usually this is the classical case of shingles. This is the classical case of shingles, right? And shingles is nothing but it is due to reactivation of, very good, it is due to reactivation of a herpes zoster virus. Okay, it is due to reactivation of the herpes zoster virus. So when does this herpes zoster gets reactivated? तो याद रख लो, if a child was affected with chicken pox in childhood, okay, if a child was affected with chicken pox in childhood, okay, and what happened, the child was not treated adequately, or maybe the chickenpox virus or this varicella zoster or this herpes zoster virus, it remained in a dormant form in the dorsal root ganglion, and when the patient became immunocompromised, that means during old age, okay, when the patient gets immunocompromised, that time this herpes zoster or varicella zoster virus gets reactivated, and that leads to this shingles usually. If these painful vesicles are present in the dermatomal segment, it is shingles. If these painful vesicles are present in this region of the trigeminal nerve, then it is called as herpes zoster ophthalmicus, right? And if this involves the ear region, then it is called as herpes zoster orticus, also known as Ramsay-Hunt syndrome. That was a question as well that we'll discuss. No issues with this. So definitely it is due to reactivation of the herpes zoster virus. ठीक है? I hope this was a very clear and easy one. Question number 36. A HIV positive patient having a CD4 count of less than 100. Definitely this was mentioned, people said me. So a CD4 count of less than 100 was given, and the patient complains of cough since 3 weeks with no expectoration. So it was more likely a dry cough. Now this I am not sure if it was mentioned or not. Okay, some people are saying it was, some people are saying it wasn't. So lower lung infiltrates were seen. Okay, I am not sure if it was mentioned or not. What is the most likely cause of infection in this condition? So please let me know your answer. What do you think on this? Jaldi se. So what have you marked? Was this the exact question? Was this the exact question, guys? So please let me know if this was the exact question usually. So, okay. So some people are saying there was sputum. Okay. Some people are saying there was no expectoration. Some people are saying there was sputum with blood spots. Something like that was mentioned. Okay. There was sputum with blood spots. So something like that kind of was mentioned. Okay. So definitely, if it is a HIV positive patient having a CD4 count of less than 100, okay, and there is cough since 3 weeks, if there is no expectoration and there are lower infiltrates, or even if there are not, what is the most likely cause of this infection? We have discussed. Please remember, usually if they ask you overall, what is the most common cause of pneumonia? Okay, acute infection of lungs with cough. Okay, dyspnea, tachypnea, all of these are features of pneumonia definitely. So what is the most common cause of pneumonia in a HIV positive patient? Then my answer is definitely strep pneumonia. But as soon as they ask me what is the most common cause of pneumonia in a patient with a CD4 count less than 200, because if the CD4 count falls down, then definitely there is a higher risk of opportunistic infection in this patient. And the opportunistic infection which causes pneumonia in this patient is definitely Pneumocystis jirovecii, which is also called as Pneumocystis carni. Okay, it is also called as Pneumocystis carni. But we know usually the X-ray of Pneumocystis jirovecii absolutely appears to be normal. The X-ray of Pneumocystis jirovecii appears absolutely to be normal. Okay, so यहाँ पे I am not sure about this one. Therefore, here my diagnosis would be Pneumocystis jirovecii definitely, or Pneumocystis carni pneumonia. Okay, because at a CD4 count less than 200, there is a high probability of opportunistic infections. Please remember. Okay, tuberculosis is most commonly found in India. Overall, worldwide, Pneumocystis jirovecii is the most common opportunistic infection. TB हर जगह नहीं लागू होता ना यार buddy. Okay, TB is more common in India, not in developed countries, right? So please remember, HIV positive. मैंने ये बहुत बार चिल्ला के बोला अपनी क्लासेस में. Overall, Pneumocystis jirovecii is much more common. In India, TB is the most common opportunistic infection. Okay, and if the CD4 count is so low, definitely TB का कोई मतलब नहीं रहता यहाँ पे. It is more likely to be, usually MAC can occur at less than 100, but there should be other features too. Okay, please remember there should be other features too. तो इसीलिए मैं confirm कर रहा हूँ, were there any X-ray findings? If there were no X-ray findings as such, then definitely more likely the diagnosis is towards Pneumocystis jirovecii. But if there were X-ray findings which were given, then definitely we can take our diagnosis towards MAC as well, Mycobacterium avium cellulare. Okay, no issues with this anybody? Please remember. Okay. Question number 37, if I ask you, which type of tracheostomy tube is preferred for pediatric patient? Now, most of the people are giving me this recall, and please remember, Mycobacterium avium was there in the option. I am not denying it. But please remember, there should be other. Jirovecii wasn't there in the option. If jirovecii wasn't there in the option, then definitely the second most common cause of pneumonia at such a low CD4 count can be MAC. Okay, then you can answer it as MAC. No issues with this anybody? If jirovecii was not there in the option. Which type of tracheostomy tube is preferred for pediatric patients? So please tell me, for pediatric patients usually. Some people are saying it was asked for long-term oxygenation in ICU patient. Which type of tracheostomy tube was preferred? That was the question. Give me the other options for this. If you have other options. So if they have asked you, ये pediatric patient वाला तो मैंने हर बार बताया, QRS में भी लिखा है मैंने बकायदा. Okay, I don't think so that you should have done a mistake over here. If they ask you about the tracheostomy tube or a ET tube, whatever it is, for a pediatric patient or for a child, definitely we tend to avoid a cuff tube due to the risk of tracheomalacia in the children and due to the risk of laryngeal edema, because we know this cuff usually that can exert the pressure on trachea causing tracheomalacia. And second, in children usually there is high amount of loose alveolar tissue. There is high amount of loose areolar tissue in the larynx, and definitely that can cause laryngeal edema, and that can further lead to laryngeal spasm and stenosis in the child. So therefore, in children or pediatric patient, uncuffed tracheostomy or uncuffed ET tube is definitely preferred. Okay. If it was not a pediatric patient, if it was only a ICU patient which was given, then definitely you can go for a cuffed tube. If it was only a ICU patient which was given, nothing adult or pediatric was mentioned, so it is a cuff tube which is preferred. Why? Because cuff tube decreases the risk of aspiration. Decreases the risk of aspiration usually, but then also the cuff has definitely a risk of trichomalacia. So therefore we have discussed in ENT which kind of a cuff is to be used. We have discussed it should be a high volume and a low pressure cuff. Okay, volume ज़्यादा होना चाहिए to decrease the risk of aspiration, but it should be a low pressure cuff. Okay, so then your answer can be a cuff tracheostomy tube. कोई दिक्कत नहीं है. Okay, so please remember that is the reason why I'm saying. See, please remember that is the reason, guys. एक तो बहुत बार क्या होता है ना, some people have marked it the other way, therefore they try to frame the questions accordingly. ठीक है? Some people have marked it other way, so therefore they will frame the question according to their will. ठीक है? So that is the problem. That is the reason why I would usually say there can be chances that there would be a difference of 10 to 20 marks here and there if you are recalling the questions. ठीक है ना? So don't get disheartened, don't get depressed if there are some if you are scoring less or most of the questions are turning out to be wrong. I've seen people who did not even get a recall of 140 or so, they passed with good marks as well. Okay, and those who are getting a recall of 180, 190 also, sometimes it happens that they actually go below that. Okay, so please remember there would be some language differences also in the framing of questions over here as well as in the actual examination, right? So don't get discouraged by that. That's most important. Moving further, question number 38. A patient with a known case of asthma has previous history of allergy to aspirin, comes with complaints of anosmia. What is the expected finding? So this was the question which has been recalled. Some people are saying that it was given that he is a case of asthma. Some people are saying it was not given that he is a case of asthma any which ways. Okay, he has previous history of allergy to aspirin. That means this patient is definitely atopic. Okay, he is having some allergy to a particular drug, and allergy to aspirin or allergy to NSAIDs, okay, is one of the important components of a triad that we have discussed earlier, and it was a previous year NEET PG question of 2022 itself. Right, and this triad is what is called as your Samter's triad, right? So in cases of Samter's triad, we have discussed the mnemonic is BAN or BAP, whatever you call it, BAP bolo, BAN bolo. Okay, B goes for bronchial asthma, A goes to allergy to NSAIDs, specifically allergy to aspirin, and N goes for nasal polyp. Okay, or P also goes for the polyp, ethmoidal nasal polyps. Okay, so these are the three features. They have mentioned two of them, that he is a case of asthma and he is having allergy to aspirin as well. So therefore, what is the expected finding in this patient? So the most, okay, so please remember, most of the, here, the patient will definitely be more likely having a nasal polyp, which is very commonly associated in an allergic patient. Why polyps will occur? ये भी हमने discuss किया था ना. We have discussed both the types of polyps, ethmoidal nasal polyps and antrochoanal polyps. Okay, antrochoanal or Killian's polyps are more common in children, and the cause behind that is chronic infection. But these nasal polyps or ethmoidal nasal polyps are more common in adults. Okay, and what is the cause behind it? In adults, it is due to chronic allergy. Okay, and here we know the patient is allergic. Okay, so if the patient is having a chronic allergy, what will happen? There would be recurrent bouts of edema. And due to that edema of the nasal mucosa, therefore there would be a polypoidal mass which will arise. Polyp is nothing but an edematous mucosa. Okay, polyp is nothing but an edematous mucosa. Okay, so due to this recurrent edema, there is a polypoidal mass which will arise, and that leads to ethmoidal nasal polyp in a patient of allergy, chronic allergy. Okay, even if asthma was not mentioned, allergy was mentioned, and that is important. Okay, so here options were, and patient develops headache and wheezing. Okay, so a question was, a female came taking aspirin for headache and now develops wheezing, and the options were, okay, great. So it was a classical case of aspirin allergy which was given, okay, due to which she developed some allergic reaction like wheezing, and the options given were IgE, extrinsic asthma, nasal polyp. So now please tell me, did they ask you about the expected finding only, or did they ask you about what is the cause behind this condition? If they ask you the cause behind this condition, then your answer would be IgE release, because due to IgE release there is sensitization and that will lead to the allergy. But if they ask you the expected finding, then your answer can be a nasal polyp. Okay, then your answer would be a ethmoidal nasal polyp. कोई दिक्कत नहीं है इसमें. Now I am not sure if most of the people have just overlooked कि सबको लगा कि यार ये प्रीवियस ईयर क्वेश्चन है, सैम्टस ट्रायड का ही है, and a lot of people have marked nasal polyp without actually focusing on the last line where they were asking either the expected finding or were they asking actually the cause behind this. ठीक है, so if it was caused, please remember what else finding can be seen. Yes, most of the people are giving me the recall of was like okay, so like there's a 50-50 over here, no issues with this. ठीक है, so if it was expected finding, answer should be nasal polyp. If it was cause, answer should be IG release. Sorry. ठीक है, answer should be IG release. No issues with this anybody? Associated findings था, तो answer is definitely nasal polyps then. Okay, answer is nasal polyps then. ठीक है, no issues with this. Shall I move further? Question number 39. What is the cause of below given condition? What is this? What is this image showing us? This image is showing us some inclusion bodies usually, and these inclusion bodies appears to be like a owl eye. So these are what are called as owl eye inclusion bodies. And owl eye inclusion bodies are due to which infection? All of us are quite aware of this. Owl eye inclusion bodies are due to infection with HHV5, human herpes virus 5, also called as cytomegalovirus. A straightforward repeat previous year question. No issues with this. So it is due to cytomegalovirus infection. We can see this owl eye inclusion bodies. No issues with this anybody? Please remember. Okay, we will discuss about RS cells also, because people have given a recall. There were Reed-Sternberg cells also in one of the images that was given to you. Okay. Question number 40 if I talk about. Here they say a patient complains of headache and fever along with nuchal rigidity. So classical signs of meningitis, the triad, there is headache, there is fever, and there is neck stiffness or nuchal rigidity in the patient. Okay. Chest X-ray reveals there is bilateral hilar lymphadenopathy. So the chest X-ray of this patient reveals there is a bilateral hilar lymphadenopathy. That means there is a lymph node involvement in and around the chest. CSF findings reveal that there are 400 lymphocytes. Okay, CSF findings reveal that there are around 400 lymphocytes with a low CSF glucose. In one of the questions, it was only given that the CSF glucose is low and the CSF proteins are elevated. But the other question, I know you will be telling me about the other question. Please remember, that was the other question people have told me, that where it was a child who was given to you, definitely with again the signs and symptoms of meningitis, but there was no bilateral hilar lymphadenopathy in that question, and in that question there was value of CSF analysis which was properly given. A normal value was given in the brackets and the low value was also given alongside. Okay? So that was a different question people have told me altogether. Don't confuse your questions together. Please remember. Okay? So this was another question. Here a patient, not mentioned with age and anything, headache, fever, nuchal rigidity, chest X-ray showing bilateral hilar lymphadenopathy, lymph node involvement, important. CSF findings revealing 400 lymphocytes. जैसे ही वो lymphocytes बोलते हैं क्या rule out करना है? We have done the table quite a number of times meningitis का. I told you meningitis is important, and that easily rules out bacterial meningitis. Please remember why? Because bacterial meningitis mein there is neutrophils which are seen in the CSF. Okay, no lymphocytes would be seen. So any which ways bacterial can be ruled out. We are left with fungal, tubercular and viral meningitis. ठीक है? Important. Okay, so important if I talk about in all these three, there would be lymphocytes which would be seen. Okay, lymphocytes which would be seen. We have different numbers, but how to rule out viral? Here they have given that the CSF glucose. I hope I am audible now clearly to all of you. Depending on that, the answer will change. Does this habit? Now I hope the connection has been re-established and I'm audible to all of you. Am I? Am I audible to everyone now? Please let me know. Okay, great. Chalo then. Great. So some people are saying there was 70% mononucleated cells. People are saying mononucleated, right? Can anybody tell me mononucleated cells usually, ठीक है, and polymorphonuclear cells are different findings, guys. Okay, polymorphonuclear cells are usually your neutrophils which are given. Okay, so if they have mentioned about polymorphonuclear cells, PMN, they usually mention it in the question. So polymorphonuclear cells, those are your neutrophils. If they have mentioned about polymorphonuclear cells, then definitely your answer should be bacterial meningitis. But they did not mention about PMN cells, right? They mentioned about mononucleated cells, and lymphocytes only have a single nucleus. Okay, lymphocytes only have a single nucleus, therefore they are called as mononucleated cells, guys. Okay, so whether they have mentioned about mononucleated cells or lymphocytes, it is one and the same thing, right? So the answer over here would be tubercular meningitis itself. Okay, polymorphonuclear hota तो definitely our answer would have been somewhat different. Okay, moving further, question number 41 now. According to psychiatric evaluation, which of the following is not a medical cause of mental health problem? ये question शायद थोड़े बहुत कम लोगों ने recall कर पाया है, but was it a question? And it was it was this one, how it was framed. Was it the same language? So according to psychiatric evaluation, which of the following is not a medical cause of mental health problem? So if I talk about this, what were the options? Elderly age group, acute onset, loss of consciousness, and auditory hallucinations. So among this, so great, it wasn't polymorpho, so it cannot be bacterial as well. Okay? So according to psychiatric evaluation, which of the following is not a medical cause of mental health problem? So please remember, among this, definitely elderly age. In this, the patient is more likely to develop a mental health problem, something like Alzheimer's disease, right? So definitely elderly age or senility is a medical cause for mental health problem. So definitely this would be your answer. Option B say this would be one of the reasons for mental health problem, a medical reason. Acute onset, I am not sure about this. Okay, so acute onset kya? So this is definitely a question mark. What was this actual option? I need to get that. Okay. Loss of consciousness, again this is a doubt, but yeah, definitely loss of consciousness can be considered as a medical cause of some mental health problem also. Okay, it can be considered as loss of like a medical cause of some mental health problem. But auditory hallucinations, please remember they are an exception. Auditory hallucinations are not a medical cause of a mental health problem. Okay, so please remember, auditory hallucinations cannot be a medical cause of a mental health problem. Please remember this. Okay, so that would be a exception, but here I am highly doubtful what was the exact framing and what was the exact option. So if you are able to recall the options of this particular question, please let me know, so I will change the question accordingly. Okay, question number 42 now. Here they say a primary gravida presents to you at 24 weeks of gestation with a blood pressure of 142 by 90 millimeters of mercury. That means definitely she is hypertensive. Okay, what will be the next best step? So at 24 weeks of gestation, that means after 20 weeks of gestation, ये तो पूरा मैंने step wise approach अपन ने discuss किया था, even in the QRS also. Okay, we have discussed OBG thoroughly. So if the patient is having high blood pressure or hypertension only after 20 weeks of gestation, okay, that is more likely a case of gestational hypertension. That means hypertension during pregnancy, right? So if it is a case of gestational hypertension, okay, further step kya tha? If along with hypertension, okay, so along with hypertension, please remember, if the patient also develops proteinuria, along with hypertension, the patient develops proteinuria, then the diagnosis will become preeclamptic toxemia. Then the diagnosis is definitely preeclamptic toxemia. Along with these two features, along with both the two features, the patient also develops features of end organ damage. ये भी discuss किया था. The patient develops features of end organ damage. Something like epigastric pain is there. There is papilledema. There is headache, nausea, vomiting. ठीक है, blurring of vision, all of these. So end organ damage is there. Then definitely that is a case of imminent eclampsia. And lastly, with all the above features, if the patient also develops GTCS, then that becomes a diagnosis of eclampsia. तो ये पूरा step wise discuss किया था. So now here definitely they have measured the blood pressure of this patient, which is high, 142 by 90 millimeters of mercury. Now what is the second important step? You will try to check whether it is only gestational hypertension or it is a pre-eclamptic toxemia or a PIH case. Therefore you need to check for proteinuria in this patient. And if you need to check for proteinuria, what is the initial step in management? So definitely you will go for urine dipstick over here. Okay. So with the help of a urine dipstick, you can assess proteinuria in the patient. Okay. So please remember, you can assess proteinuria with the help of just a urine dipstick. Okay. No issues with this, anybody? Please remember. So next best step is definitely to check for urine dipstick analysis to be done for proteinuria. Question number 43. Which of the following is the most commonly used agent for local anesthesia? So that was the question. Some people are saying it was IVRA, that is intravenous regional anesthesia, or local anesthesia. The answer will remain same. Don't worry about that. Okay? So which of the following is the most commonly used agent for local anesthesia or IVRA? So your answer would be straightforward lignocaine, which is a sodium channel blocker. No issues with this. So please remember, lignocaine, also called as your lidocaine, it is the most commonly used local anesthetic we know, right? So please remember. And lignocaine is generally used along with adrenaline at times. So here we can use higher doses of lignocaine also. Okay, if we use it along with adrenaline, we can use the higher doses. Normally it can be used up till 3 mg, but if you use it along with adrenaline, this was a INSET recall question. If you use along with adrenaline, then a maximum dose of 7 mg can also be given to the patient. Okay, that's important. कोई दिक्कत नहीं है इसमें. Please remember. Bupivacaine is cardiotoxic and therefore it is not a commonly used local anesthetic that we know, right? That's important. Question number 44. Xerophthalmia is due to deficiency of straight one-liner, important, biochem, PSM, everywhere to be discussed. Ophtha, I don't think so. Mistake should have been done. इसमें तो गलती नहीं करी ना भाई. Xerophthalmia is due to deficiency of. Even if it was 34 weeks, you will check for proteinuria only. अगर 34 week gestation भी था, then also you will check for proteinuria. क्योंकि you need to assess whether she is a pre-eclamptic or not. So xerophthalmia is due to deficiency of. I hope this is very easy for all of you. It is due to deficiency of option B, vitamin A. Okay, so vitamin A deficiency causes xerophthalmia or dryness of eyes usually. We have discussed about the WHO staging as well, right? So no issues in this, I hope so. And here there was another question. It is an 8-month-old child, I hope so. Okay, it is an 8-month-old child who was having recurrent infections, right? The child was having some recurrent infections and now he is also having vitamin A deficiency, right? The child is having vitamin A deficiency. So what is the dose? Okay, what is the dose of vitamin A which should be given to the child? So the dose of vitamin A that we have discussed already, we know if the child is less than 6 months old, the dose of vitamin A to be given is 50,000 international unit. But we generally tend to avoid it less than 6 months unless and until the child has a deficiency. अगर बच्चे में deficiency है तभी तुम ये dose देते हो. Otherwise, in the normal national immunization schedule of India, we generally give the first dose of vitamin A solution at 9 months, right? So usually after 6 months till 12 months, the dose of vitamin A is generally 1 lakh international unit. It is 1 lakh international unit, and after 12 months of age or after 1 year of age, it is 2 lakh international units. Okay, it is 2 lakh international unit. So if the question was the child is 8 months old, definitely the answer should be 1 lakh international unit. Okay, please remember. Some people are saying the question was twisted somewhat, that the child is given half dose on the previous day and the other half dose is to be given, something like this. Okay, so if you feel so, please just type the corrected question as well in the chat box. Okay, we'll correct it. Question number 45. A patient presents to you with markings around the neck, okay, with markings around the neck over the sun exposed areas which appears hyperpigmented. Okay, so hyperpigmented markings around the neck over the sun exposed or the photosensitive areas, definitely they are talking something about Cazal's necklace. Okay, so people mentioned that this time image of Cazal's necklace was not given, rather for Cazal's necklace they have mentioned it in the word format. Okay, so there were some markings which were hyperpigmented in nature over the sun exposed areas around the neck. So it is a case of Cazal's necklace, which is a type of dermatitis which is associated with pellagra. Okay, and pellagra is due to deficiency of vitamin B3, which is also called as niacin. So here the patient is most likely suffering from the deficiency of vitamin B3, also known as niacin. Okay, which is characterized by 6 D's, right? Diarrhea, dementia, dermatitis, depression, delirium, and death. These are the 6 D's of pellagra. No issues with this, anybody? That's important, yeah. Okay, chalo. Question number 46. Again, a straight one-liner, easy peasy question. No thing to be discussed as such. Melanin is derived from. So we know melanin is a pigment which is produced by the melanosome, which is produced by the melanocytes, and it is packed in the melanosomes and distributed to the keratinocytes, and it imparts the color to skin. Melanin is of two types, eumelanin and pheomelanin, that you might have discussed in derma as well. So this melanin is derived from which of the following amino acids, they had to ask you. They only confused you because they know you might get confused because there is another one. There is another substance which is called as melatonin. This melatonin hormone is synthesized from tryptophan, and this melatonin is responsible for maintaining the circadian rhythm of the body. It is responsible for maintaining the circadian rhythm of the body. Whereas this melanin is a pigment actually which imparts color to the skin, and it is derived from amino acid, that is tyrosine. That is a straightforward question. Okay, so it is derived from tyrosine. Question number 47. A patient suffering from sickle cell anemia, what changes will be seen on gene sequencing? I feel this was the question, and these were the options which were given. People have told me. ठीक है, sickle cell anemia का genetic mutation का case था. Okay, that was the question, straightforward. So here all of us are quite aware. Sickle cell anemia में what is the gene mutation that we usually get? So here there is some problem in the beta globin chain. So there are two chains in the hemoglobin. Hemoglobin is made up of heme plus globin chains, and these globin chains are alpha 2 and beta 2. In an adult hemoglobin, there are 2 alpha chains and 2 beta chains. So if I talk about the beta globin chain, usually here in this beta globin chain at the 6th position, what happens? One amino acid, that is glutamate. This glutamate, it goes and it is replaced by valine. So glutamate goes and valine is welcomed. That's how you remember it, right? So here in the beta globin chain at the 6th position, okay, at the 6th position, glutamate is replaced by valine. Okay, so that should have been your answer. Okay, I hope this was the question. अगर ऐसा ही था तो answer would be option C. Question number 48, right? Which of the following is not a micro element? Okay, so micro elements are the ones which are required in trace quantities usually. Okay, so which among the following is not a micro element? So that's a very easy question, I feel. Usually all the other elements are required in micrograms. Only one element which is measured and which is required in milligrams. I hope all of you are quite aware of that, and that is calcium, right? So please remember, here calcium is not a micro element, rather it is a macro element. Rather calcium is a macro element. Rest all zinc, copper and selenium, these are micro elements which are only required in minute or trace quantities for the body. Okay? That's important. Straight question from PSM and biochemistry. Question number 49. An office worker complains of muscle weakness which worsens as the day progresses. So classical case tha ye. Everybody had to mark it correctly. Okay? And his symptoms improve on administration of neostigmin. So the symptoms improve on administration of a cholinergic drug like neostigmin. What is the most likely diagnosis in this case? Okay, if the symptoms would have worsened on neostigmin administration, then the diagnosis would have been cholinergic crisis. But here the symptoms of this patient improve on administration of a cholinergic drug like neostigmin. So definitely the case is myasthenia gravis, a classical case where the patient is having muscle weakness which will worsen throughout the towards the evening or as the day progresses, and it improves on administration of a cholinergic drug like neostigmin. Why? Because in myasthenia gravis, guys, there are antibodies. It is an autoimmune condition where there is production of antibodies targeted against the acetylcholine receptors. So there are acetylcholine receptor antibodies which are produced. Okay, therefore the acetylcholine is not able to bind to these receptors, and the action potential is not carried further. Okay, the impulse is not carried further, therefore the patient complains of muscle weakness. Okay, so that is a problem at the neuromuscular junction over here. Okay, that is a classical case of myasthenia gravis. I don't think so there should have been any issue with this. I'm not sure the third question. Second question I've included for myasthenia, but the third question people are saying there was like about physostigmin. Please let me know the question, because some people are saying there was a question of physostigmin, some people are denying it completely. There was no question of physostigmin as such. Duchenne's muscular dystrophy, we know it is usually seen in a child. Okay, important, it is usually seen in a child, and the child dies by the age of 12 to 15 years. Okay, the child gets bedridden by the age of 10 years usually, or wheelchair bound by the age of 5 years itself, and the child will have a classical Gower sign. Okay, and there would be a proximal muscle dystrophy. So all of these features, and not only the limb muscles would be involved, but also the diaphragmatic muscles would be involved as well. Okay, please remember this. Question number 50, if I talk about a patient complains of muscle weakness which worsens as the day progresses. Again, a similar line it started with, but here they mentioned that there was drooping of eyelids, and drooping of eyelids is what is called as ptosis, right? So drooping of eyelids is what is known as ptosis, guys. Please remember, as we have discussed. And this drooping of eyelids or ptosis, it improves by administration of edrophonium. So they mentioned in one of the questions it was neostigmine, the other question they mentioned about some tensilon test, right? So what is the most probable diagnosis? So again, here the answer is myasthenia gravis. Reason being, please remember, a lot of people are saying there was ocular myasthenia also in the option, but if they have mentioned about bodily weakness as well, muscle weakness of the limbs and the extremities, please remember, then you need to answer it as myasthenia gravis itself. If they would have only mentioned about the extraocular muscles, if they would have only mentioned about drooping of eyelids and nothing else, then my answer would have been ocular myasthenia. But here, as they are mentioning also about the limb muscles, muscle weakness apart from that as well, so it's definitely myasthenia gravis then. Okay? Question number 51. What is the least common risk factor for mucormycosis? I feel again a very easy question. Mucormycosis, we know it is a severe fungal infection. Okay, it is a severe fungal infection which is angio-invasive in nature. That means it involves the blood vessels. Okay, and that is the reason why it causes ischemic necrosis, which leads to formation of a black eschar, जिसकी वजह से तुम्हें हर जगह black spots दिखते हैं. Okay, so there would be black spots everywhere. Some people are saying black spots were given. I'm not sure if it was a separate question where there was some black mass or black spots in the nose or something like that. People are saying that was one of the questions. Please let me know if it was. Okay, so definitely sorry, it is a severe fungal infection caused by rhizopus and mucor fungi, okay, which is angio-invasive in nature. So here mucormycosis is generally seen in which patients? We have discussed that in ENT as well. It is commonly seen in immunocompromised patients. And who are usually immunocompromised patients? Patients who are elderly, who are known diabetic. Okay, so the patients who are elderly, who are known diabetic, okay, who are on some chemo or radiotherapy. Why? Because in chemo or radiotherapy, the patient can suffer from leukopenia. Okay, the patient can suffer from leukopenia, and most important, the patient who has a long-term steroid use history. Okay, so long-term steroid use history will also lead to a immunocompromised status in the patient, and which was generally seen with COVID-19. So COVID-19 was not a risk factor. Long-term steroid use was a risk factor for mucormycosis in the patients. Okay, that's important. So yaad rakh lo, neutropenia definitely. Leukopenia is nothing but neutropenia only. So neutropenia definitely can lead to recurrent infections in the patient. Long-term steroid therapy, uncontrolled diabetes mellitus, but broad spectrum antibiotic use will make the patient prone for bacterial infections and not for fungal infections as such. Okay, the patient would be more prone for antibiotic resistance and bacterial infections, not for severe fungal infections. Okay, so अगर इसमें से मुझे निकालना पड़े, definitely the least common risk factor I would say. See, least common बोला उन्होंने, not a risk factor नहीं बोला. The reason being, long-term antibiotic use or broad spectrum antibiotic use can have definitely some effect on the immunity status of this patient, and the patient can develop a fungal infection. But if I compare all the other options, all the other patients would have a higher risk as compared to the option C. Okay? So here the odd man out is option C only. Okay? Chalo. Question number 52, if I talk about a patient complains of episodic headache, classical triad दिया था यार, इसमें तो गलती नहीं होनी चाहिए. A patient complains of episodic headache, palpitations and sweating. Sweating is also termed as diaphoresis, right? So this episodic headache, रुक के headache क्यों होता है? Because there is an episodic hypertension in this patient, and this episodic hypertension क्यों होता है? Because there is release of catecholamines. Okay, there is release of epinephrine, norepinephrine. So these catecholamines are released in episodes. Whenever these are released, the patient experiences hypertension, and that leads to headache in the patient. There is palpitations and sweating. So this is a classical triad of which tumor? Anybody? Where there is excess of catecholamine release. So here, MRI also reveals a small mass in the adrenal gland. What is your diagnosis? I hope all of you have marked it right. It is a classical case of option B, pheochromocytoma. मैंने बोला था pheochromocytoma एक सरकारी question है. It is mostly asked in the examinations. They have definitely confused you with other adrenal tumors like adrenal adenoma or adrenal cancer. Okay, and they have specifically mentioned that the mass was found in the adrenal gland itself. Okay, but please remember, in all these below given conditions, the mass would be situated in the adrenal gland itself. Okay, but in cases of pheochromocytoma, there would be this classical triad of episodic headache, palpitations, and diaphoresis due to the excessive catecholamine release, because pheochromocytoma is a tumor of the chromaffin cells. Okay, and these chromaffin cells are known to secrete catecholamines, okay, which are present in the adrenal medulla. No issues with this, anybody? I hope this is very clear with all of you. Okay? Investigation of choice, if they ask you, that is a very commonly repeated question. It is plasma fractionated metanephrines. Okay? So plasma fractionated metanephrines are the investigation of choice for pheochromocytoma. Whereas urinary 24-hour urinary catecholamine levels or 24-hour urinary VMA levels. Okay, so all of these are screening tests. Investigation of choice is only one, that is plasma fractionated metanephrines. Radiological investigation, if they ask you, answer is MRI, and if it is not picked up on MRI, if it is very small, then a MIBG scan has to be done. Okay? Surgical excision is the treatment of choice for pheochromocytoma, but during surgical excision, what can happen? Due to improper handling of the adrenal gland, there would be excessive release of catecholamines all of a sudden, and there can be hypertensive crisis in the patient. That is the reason why you need to give some drug like phentolamine. Okay, so IV phentolamine drip has to be started while you are performing surgery for a pheochromocytoma. Okay, all of these are important things. Question number 53. A patient had history of fall. So here they have given that the patient had some history of fall. Now the patient presents to you with the following X-ray finding. What is the diagnosis? And what is the X-ray? अब मुझे ये समझ नहीं आ रहा. People are saying कि सर आपने तो बोला था कि बोन ट्यूमर से क्वेश्चन आता है, तो मैंने बोला था बोन ट्यूमर से क्वेश्चन आता है, इसीलिए मैंने पूरा टेबल पढ़ाया था. I said GCT is सरकारी. It has been asked quite a number of times. That does not mean ना कि GCT ही हर बार पूछेंगे भाई. हाँ, I'm just not sure why you people are only focusing on one thing. अगर एक आई है तो इसका मतलब ये नहीं कि वही चीज आती है, उसके आसपास की चीजें जरूर आ सकती है ना. So please remember, always study the adjacent things also to that particular topic. ठीक है? So GCT is definitely very common, but not always asked, right? So here you can see, and this we have discussed also. Rather one-liner है ये. Most common bone tumor. Okay, benign bone tumor to be specific. Most common benign bone tumor. Answer क्या है? Most common benign bone tumor is a osteochondroma. But here, as I've told you, there's an exception. If they ask you which is the most common true benign bone tumor, answer changes. Okay? Because this osteochondroma is not actually a true benign bone tumor. Right? So please remember, most common true benign bone tumor agar pucha jaye, then the answer would be osteoid osteoma. Then the answer would be osteoid osteoma, which arises from the diaphysis of the shaft of the long bone. Okay? So here, definitely you can see at the metaphyseal region there is overgrowth from the bone which is arising, and this overgrowth which is arising is what is called as osteochondroma, also known as exostosis, the overgrowth, bony overgrowth. Okay? So please remember, so this is a likely case of osteochondroma. Osteosarcoma is common at the metaphysis, yes, at the lower end of the femur itself, but over here which kind? We cannot see any overgrowth, rather we can see elevation of periosteum, giving us the Codman's triangle. Okay, it will give us a Codman's triangle, and apart from Codman's triangle we can also see the sunburst appearance or the sun ray appearance due to the periosteal reaction. Okay? In Ewing sarcoma, it does not involve the metaphysis first, second it involves the diaphysis commonly, and it gives which appearance? It gives a onion peel appearance of the diaphysis or the shaft, and it will resemble osteomyelitis because it leads to fever, it leads to swelling and all the other inflammatory signs. ठीक है, important. Enchondroma commonly it is seen in the short bones or the small bones like phalanges or the metacarpals. ठीक है, so it is commonly seen in the small bones of hand and feet, and over there we can see a soap bubble appearance within the small bones, right? So that is what is an enchondroma. So here the diagnosis is osteochondroma. Even chondroblastoma was one of the options. Here definitely you can see it is a bony overgrowth which is arising from the metaphyseal region. The answer is more likely to be osteochondroma itself. It is a case of exhaustosis, which is very common. ठीक है. Question number 54. A 24-year-old welder complains of a foreign body sensation with the following slit lamp examination finding. What is the management? So such a finding was seen. ठीक है, कोई ब्राउन कलर का या ब्लैक कलर का स्पॉट बोल रहे लोग. Okay, so such a finding was definitely seen in the image. So it was due to the metallic foreign body, most likely a iron foreign body. Okay, so it is a welder, so high risk of foreign body. Okay, so therefore there was a metallic or iron foreign body which was seen. What is the management? So if they ask you about the foreign body in eye, this was a previous year topic as well which has been asked. They previously asked what is the best investigation. First line, if they ask you, answer is ultrasound B scan has to be performed. Okay, if they ask you the first line, radiological investigation. If they ask you the best radiological investigation, answer is the NCCT scan. Okay? And if they ask you what is the treatment for this, definitely answer should be removal of this foreign body with a 26 gauge needle. As you can see, it is over the cornea. Here it has to be removed with the help of a 26 gauge, a very fine needle. 26 gauge सबसे छोटा gauge होता है ना. So here it should be removed with the help of a 26 gauge needle usually. ठीक है, observation could not be done because if you do observation that can lead to further conjunctivitis and further spread of infection in the patient as well. ठीक है, antibiotics and steroids would be given, but what is the next step? What is the best management? If they ask you, answer always removal of the foreign body immediately. Okay, removal of the foreign body immediately. No issues with this anybody? याद रखो, अगर वो posterior segment में होता तब बात अलग थी. If it was in the posterior segment and it was not causing any harm, that was a very previous year question. Okay, very old question that had come. Posterior segment mein and not causing any symptoms in the patient, then the funda is different. Then you can go for observation as such. But here, if it is in the anterior chamber, anterior segment, and if it is causing symptoms, definitely you need to go for immediate removal with a 26 gauge needle. Okay, that's the best treatment. Moving further, identify the type of placenta previa. Now just confirm whether it was A or whether it was B. Some people are saying the placenta was appearing to be beneath the head of the baby. Some people were saying it was not appearing to be beneath the head of the baby. दोनों में से बता दो कौन सा था जल्दी. Which was the one, A or B in the examination? Fast, because then your answer would change. Okay, then your answer would definitely change. ये पूरा हमने discuss किया था. There are 4 grades of placenta previa. If it is only lying in the lower segment, if it is only here, then it is called as a low lying placenta. If it is touching the margin or it is touching the internal os, it is called as a marginal placenta previa. If it is partially covering the os, it is a type 3 placenta previa, and if it is completely covering, it is a type 4 placenta previa. It was A, right? Most of the people are agreeing that it was A. So this was definitely not the one which came in the examination. So it was only touching the internal os. Okay, if it is only touching the internal os, definitely answer should be option B. It is a marginal or a type 2 placenta previa. People who have marked low lying, guys, low lying तो हर एक type का placenta previa हुआ ना यार. Low lying is a type 1 placenta previa when the placenta previa is only over here. It is not even touching. तुम अगर baby के सर के नीचे बोल रहे हो तो how it can be low lying? Low lying वाला तो बिल्कुल गलत होगा. Either it can be marginal or partially covering. Okay, if most of the people are saying it was marginal, so it is a type 2 or a marginal placenta previa if it is only touching the internal cervical os. कोई दिक्कत नहीं है इसमें. That's important. Question number 56. What is the location of uterus just after delivery? ठीक है, that also we have discussed. This was a previous year NEET PG question also. It was just asked like after 2 days of delivery. NEET PG का question जो discuss किया था हमने, it was after 2 days of delivery, what would be the location of the uterus? And after 2 days of delivery, it was 2 fingers below the umbilicus, right? It was given two fingers below the umbilicus. It was given, right? two fingers below the umbilicus, that is 2 to 3 centimeters below the umbilicus usually. After 2 days of delivery, I'm saying. And what is the rate of involution of the uterus? The rate of involution of the uterus is generally, on an average, it is 1 to 2 centimeters per day. Okay, 1 to 1.5 only, not even 2. It is 1 to 1.5 centimeters per day, right? So usually in 2 days it will go 2 centimeters or 3 centimeters down maximum. So if it is 2 centimeters or 2 fingers below the umbilicus after 2 days, अगर ये किसी ने question किया होता, so it was very easy to mark this one as well. Immediately after delivery or just after delivery, the location of the uterus would be at the lower border of the umbilicus. If lower border of umbilicus was not mentioned, it would be below the umbilicus, which should have been marked. Okay, it is at the lower border of the umbilicus, the location of uterus. Okay, and we know the uterus remains an abdominal organ till 10 days. After 10 days, it usually regresses and it becomes a pelvic organ, after which it is very hard to access the organ. Therefore, if you need to perform a perpural or a postpartum tubectomy, you need to perform it within 2 to 3 days itself. ठीक है, maximum within 10 days. कोई दिक्कत नहीं है इसमें. So please remember, it is just below the umbilicus or the lower border of the umbilicus. That's important. A 60-year-old male, 60-year, okay, so 60-year-old male, obese smoker with dyspnea on exertion. Some people are saying they mention coronary artery disease. Some people are saying they mention dyspnea on exertion. Whatever it is, both are features of heart disease itself. Now the patient presents with below given finding. In finding, what was given? There was gangrene, okay, which was given for the lower limb, okay, of the toes. So gangrene of toes was given generally, okay, and gangrene is due to ischemia definitely, and ischemia is due to blockage of the arteries, okay. So what is the diagnosis in this condition? Now a lot of people have given me the diagnosis. It was definitely easy that sir, वो तो Buerger's disease था, which is also called as thromboangiitis obliterans. But some people have not. Yes, atherosclerosis was one of the options that I had to ask you yourself. So atherosclerosis was one of the options, right? So now I need to discuss that only. Please remember, if you are saying it was Buerger's disease or thromboangiitis obliterans, guys, important was one. First of all, we have discussed what was the criteria to diagnose what was the criteria to diagnose Buerger's disease? It was called as Olin's criteria, and we'll discuss Olin's criteria के 3 features क्या थे. It is more commonly seen in male less than 45 years of age group. Second, there should be a history of tobacco use. That means the patient should be a smoker or a tobacco eater, whatever. And third important, there should be signs and symptoms of distal ischemia, right? There should be signs and symptoms of distal ischemia, that is pulselessness vagera, right? Poikilothermia, pulselessness, all of these signs of distal ischemia should be present, right? So here signs and symptoms of distal ischemia were there. Definitely gangrene हो चुका है. और क्या चाहिए तुम्हें? History of smoking is also there. Important is the patient was a male definitely, but it was not less than 45 years of age. The patient was an elderly male which was given. ठीक है. Apart from that, most important guys. They mentioned coronary artery disease. If you are saying that coronary artery disease or dyspnea on exertion was given in the question, that means here not only, please remember, not only the limb vessels, that is lower limb or upper limbs are affected, rather the coronary vessels are also affected, okay. And usually Buerger's disease or thromboangiitis obliterans is more common in the limbs, okay. As we have discussed, I have always written lower limbs more than upper limbs, ठीक है. So lower limbs में ज़्यादा common होता है, we know that. But it is not very common in the coronary arteries. If they are talking about coronary arteries or all of these features of heart disease, then the answer should be atherosclerosis. Then your answer should be atherosclerosis. Agar CAD or dyspnea on exertion nahi tha, then your answer can be Buerger's disease or thromboangiitis obliterans. No issues with this anybody? That's important. ठीक है ना? Because risk factor for atherosclerosis, most important risk factor for atherosclerosis is, जरा याद करना, smoking. ठीक है. तो अगर तुम स्मोकिंग के हिसाब से बस उसको बर्गर्स मार्क कर रहे हो, तो भाई ये भी सोचो कि एथेरोस्क्लेरोसिस में भी मोस्ट इंपोर्टेंट रिस्क फैक्टर स्मोकिंग ही था, ओके. एंड द एज इज मोर लाइकली inclined towards atherosclerosis as the diagnosis. No issues with this? Question number 58. Most important risk factor for mastitis. So mastitis is nothing but the inflammation of the breast tissue, okay. And we know mastitis, what is the most common cause for mastitis? The organism responsible is Staph aureus. And what is the source of the Staph aureus? definitely it is the baby's mouth or the oropharynx of the baby, and it is more common during the lactation period when the patient experiences mastitis. But ऐसा ही थोड़ी जाएगा. So whenever the patient has a cracked nipple, the chances of Staph aureus infections will increase tenfold, and therefore this is the most important risk factor. If the baby bites, for example, or if there is some crack due to eczema or due to dryness, okay, so that increases the risk of Staph aureus infection, and that leads to mastitis in the patient. So cracked nipple is the most important risk factor. Okay, no issues with this, anybody? That was a straightforward question. Question number 59. Identify the type of pelvis. There are 4 types of pelvis we have discussed already. If it is a round cavity completely, it is called as a gynecoid pelvis. Then if it is a flat pelvis where the transverse diameter is more than the anteroposterior diameter, then it is more likely to be a platypelloid or a flat pelvis. If it is a heart-shaped pelvis, it is a male type pelvis known as android pelvis. Okay? So it is a male type pelvis known as android pelvis. And if it is oval, vertically oval, when the AP diameter is more than the transverse diameter, then this is what is called as an anthropoid pelvis. So here जो दिया था तुम्हें, a lot of people were saying that it was a completely round pelvis. Okay, completely round pelvis. But most of the people are saying कि जो horizontally ये red line mark थी ना, so it was to actually make it sure that the horizontal diameter or the transverse diameter is actually more than the anteroposterior diameter, and such kind of a pelvis is actually called as the platypelloid or the flat pelvis. If it was completely round, if most people are supporting that, then definitely it can be a gynecoid. But what people are saying me is the transverse diameter was slightly more than the anteroposterior one, and therefore it is actually a platypelloid or a flat pelvis, which is the rarest type of pelvis though. Okay, gynecoid being the most common type of pelvis and the most favorable for normal vaginal delivery as well. ठीक है, याद रखना. Android pelvis can lead to deep transverse arrest in the patient, and anthropoid can lead to a persistent occipito-posterior position that we have discussed already. Question number 60. Infectivity is also known as. I am doubtful about these options because we have discussed. Okay, so secondary attack rate is actually a marker of communicability, okay, or spread of the disease. So if they ask you marker of communicability or marker of spread of the disease, answer can be secondary attack rate. But marker of infectivity is more likely, marker of infectivity can be secondary attack rate as well. But if we had other options, then it would have been better. People are saying the other options were serial interval, incubation period, and case fatality rate. Any which ways, nothing of them is actually telling us about infectivity. Serial interval is what? It is the time interval or the time gap between the primary case and the secondary case. Okay, so the time gap between primary and secondary case is serial interval. Incubation period is from the entry of organism till the first signs and symptom appear. This time period is what is called as the incubation period. Okay, and case fatality rate is, for example, out of all the deaths in that population, how many deaths actually occur due to TB? Okay, that is what is called as the case fatality rate. Out of all the cases of TB, how many deaths have occurred? So that is what is called as the case fatality rate. That will tell you about the virulence of an organism. How much virulent it is. Highly virulent मतलब fatality ज़्यादा है, right? So please remember. So virulent organism ज़्यादा है तो fatality ज़्यादा होगी. But infectivity or the spread of infection or the communicability is definitely told by the secondary attack rate. Okay, important. No issues with this, anybody? What is the most common indirect cause? This was a direct question. कितनी बार मैंने class में भी repeat किया है. I hope like Prasan sir also discusses this quite a lot now. So I hope so you all have marked it right. What is the most common indirect cause of maternal mortality? Most common direct cause was easy. Most common direct cause of maternal mortality was easy. It was PPH itself. Okay. But most common indirect cause, if they mention, most common indirect cause of maternal mortality, we know it is anemia. Most common indirect cause of maternal mortality is anemia. That's important, right? Please remember this. And maternal mortality, as we also know, it is considered as death of the mother until 6 weeks after delivery. That is till the whole period of perpurium. Okay? So maternal mortality is death of the mother during pregnancy, death of the mother during delivery, or till 6 weeks after delivery. This was the question which came in FMG June 2022. Okay, maternal mortality is considered until how many weeks after delivery? Answer was 6 weeks after delivery. Okay. Question number 62. Which of the following is the correct sequence of lochia? Okay, lochia is nothing but the fluid which comes out after delivery from the vagina. Per vaginally, the fluid which comes out after delivery is what is called as lochia. Okay, and this lochia, it is of 3 types usually. Okay, it has 3 colors. Initially after delivery, what happens? There is bleeding which is occurring. So initially, jo aega fluid, it would be red in color. So that is what is called as lochia rubra. Then it is due to presence of RBCs in the fluid. Then this RBCs would be replaced by WBCs usually, and then it will turn as almost pale yellow in color. That is serosa. Okay, and lastly it would be white in color. That is alba. And this alba, it is nothing but it is due to the decidua. Decidua is nothing but the pregnant endometrium. Jo endometrium which is present during the pregnancy, that is what is called as a decidua. So when the decidual shedding starts, then it leads to this presence of alba. So lochia rubra, lochia serosa, and lochia alba. RSA is the mnemonic. In this sequence usually it appears. For the first 4 days it is lochia rubra. Okay, for 4 to 8 days it is generally lochia serosa, and after 8 to 10 days usually it is, so some books say it is 5 to 9 days. So it's better to remember 5 to 9 days it is lochia serosa, and after 9 days definitely it is lochia alba which appears. Okay? So here the answer would be option C, rubra, serosa and alba finally. Okay? Question number 63. A 30-year-old nulliparous female comes with dysmenorrhea. Dysmenorrhea is nothing but painful menses. So जब menses के वक्त pain होता है, that is what is called as dysmenorrhea. And this young female is also having dyspareunia. Dyspareunia is pain during sexual intercourse. So she is also having dyspareunia. Okay. So dysmenorrhea, dyspareunia in a younger female. Okay, it's more likely suggestive of endometriosis. First only. On per vaginal examination, there is some nodular feel. Okay, there is some nodule-like growth or nodular feel which is felt per vaginally. So what is the likely diagnosis? So in this, definitely the likely diagnosis is endometriosis. Some people said that there was tender uterus which was mentioned. There was a tender uterus on palpation which was mentioned. Tender uterus on palpation is a more likely feature of adenomyosis. Okay, endometriosis में क्या होता है? The endometrium is present outside the normal site. It is present at some ectopic site. It can, most commonly it is usually the ovaries. It can be present anywhere else as well, right? So that is what is endometriosis. And in adenomyosis what happens? This endometrium is present within the myometrium. Okay, so that is why during each menses, whenever there is endometrial shedding within the myometrium, that leads to pain usually. Okay? So please remember here, more likely diagnosis would be endometriosis. If it was a tender uterus, then the diagnosis would have been adeno, but problem is the age was not at all favoring adenomyosis, because adenomyosis is more common in an age group which is perimenopausal or postmenopausal. So perimenopausal or postmenopausal age group mein common hota hai adeno. Okay, please remember this. Adnexal mass tha history pe, that was a different question. Okay, yeah. That what I've got, that was a different question where there was a tender uterus on palpation. Okay, now. So thank you, Upendra. So that was a different question. I'll come up with that question as well then. Okay. Question number 64. Identify the arrow marked area. So I'll mark it for you. Okay. So here first of all, sorry, the arrow marked area was somewhere over here, I feel, right? It was somewhere over here. The one that I've marked in red, right? I hope this was the important one. Okay. So I hope something this kind of a question was there. Okay, and here they have asked you about the ribs, right? Here they have asked you about the ribs. This is a chest x-ray PA view which was given to you. Okay, and here that you can see the first one, the first rib, we know it is circular. Okay, the first rib is circular and it goes usually at the level of the clavicle itself. Okay, so here the first rib you can see it is circular and it goes at the level of the clavicle. Then this one is your second rib, this one is your third rib, and this one that is marked is your actually fourth rib. Okay, the one which is marked is your fourth rib. Now if I talk about the fourth rib, please remember the ones which are dense, जो दिख रहे हैं अच्छे से white दिख रहे हैं ना, that is the posterior end on the anterior end. So please remember the ribs are usually complete on the posterior side. The ribs are complete on the posterior side. ठीक है? So please remember they articulate with the facets, the costal facets on the posterior side. So the ribs are complete on the posterior side. But anteriorly you can see they are disappearing. Why they are disappearing? Anteriorly, these ribs disappear because they are actually articulated with the costal cartilage. They are articulated with the coastal cartilage, and cartilages हमें सबको पता है, cartilages are radiolucent. That means they appear black on the X-ray, and therefore the ribs appear as incomplete. Anteriorly, they don't appear to be complete. ठीक है? So definitely, if they have marked it over here, it is more likely the posterior end of the fourth rib. Okay, it is more likely the posterior end of the fourth rib. Please remember this. ठीक है? Posterior part of the fourth rib. कोई दिक्कत नहीं है इसमें. Important. Question number 65. Ventouse. Ventouse is also another name used for vacuum delivery. ठीक है? So ventouse is contraindicated in all of the following except. So ventouse or vacuum delivery is contraindicated in all of the following except. So ventouse किस किस में contraindicated होगा? If the fetus is having distress, if the fetal heart rate is less than 110 beats per minute, or if the fetal scalp blood pH is less than 7.2. These are the two indicators of fetal distress, right? So if the fetus is in distress, definitely you will not actually let the fetus go into more distress, and you will not like to perform a normal vaginal delivery. Fetal distress is the most common indication of cesarean section. So here you will go for the C-section. Prematurity में we will not go for a ventouse, because please remember, if it was ventouse, okay, so people have told me, Upendra, that the dense part of the rib was marked. If the dense part of the rib was marked, then definitely it is the posterior part. If the radiolucent part was marked, then it can be the anterior part of the rib. Okay. So if I talk about the prematurity, if you apply the ventouse or the vacuum over here in a premature baby, there would be high risk of cephal hematoma in this child. Okay. So therefore, in premature children also we try to avoid ventouse as well. Okay. And in placenta previa, they have not mentioned the grade as such, but usually in placenta previa cases, we try to avoid ventouse because there would be risk of rupture. If you apply more pressure, there can be risk of rupture, and that leads to bleeding, which can be fatal at times as well. So therefore, in all these conditions, we do not apply ventouse or vacuum, but maternal exhaustion is rather the indication of ventouse ना यार. जब mother थक गई है labor में, 3 idiots याद करो, जब वो मोना थक जाती है, then only they apply that vacuum ना. So please remember, maternal exhaustion जब हो जाता है, then we try to help the mother with the help of ventouse or forceps. ठीक है? So maternal exhaustion is rather an indication, so it is not a contraindication for ventouse delivery. ठीक है? Please remember. Question number 66. Oxytocin vial was given. Ventouse was contraindicated was asked, or ventouse was... I feel this was the question. Ventouse is contraindicated in all of the following except people were saying. Most of the students have given an except. So I am not sure if except was seen in the question. Because a lot of people, like 90% of the students have given except was present in the option. So that has to be taken care of, except option में था या sorry question में था या नहीं था. So oxytocin vial was given any which ways. उन्होंने शायद mention भी किया था. I'm not sure if they have mentioned that the drug in the given image, or they have directly given that oxytocin is contraindicated in. Okay. So if so please remember, if it was oxytocin is contraindicated in, please remember ऑक्सीटोसिन. अगर तुम्हें एक मार्क करना है उसमें से, प्लीज रिमेंबर, अगर तुम्हारा है वैसे तो इन ऑल दीज कंडीशंस वी डू नॉट गो फॉर अ वेंट्यूज और अ वैक्यूम डिलीवरी, बट इफ यू नीड टू मार्क वन, अगर उपेंद्र तुम्हें चाहिए, द फीटल डिस्ट्रेस वुड नॉट बी आंसर. फीटल डिस्ट्रेस के साथ तुम कभी भी वेंट्यूज या वैक्यूम अप्लाई नहीं करोगे, बिकॉज ओवर देयर दैट इज अ इंपॉर्टेंट इंडिकेशन ऑफ सिजेरियन सेक्शन. ठीक है, दैट्स इंपॉर्टेंट. ठीक है, चलो. ऑक्सीटोसिन इज कॉन्ट्राइंडिकेटेड इन, प्लीज रिमेंबर, ऑक्सीटोसिन इज कॉन्ट्राइंडिकेटेड इन विच कंडीशन? Option A says abnormal lie of fetus. If it is even an abnormal lie of fetus, okay, they have not mentioned it is absolutely a transverse lie. Okay, so if it is an abnormal lie of fetus, if it's the oblique lie also, we can give oxytocin to the patient for augmentation of labor. Okay, and therefore, so in an abnormal lie of fetus also oxytocin can be given. Hypothyroidism definitely. Okay, hypothyroidism में भी तुम oxytocin दे सकते हो किसी भी patient में, there is no issue as such. Now there were two important conditions. I am just not sure were both of them the same option or not. Were both of them the same option or not? कुछ लोग बोल रहे हैं PIH नहीं था, cardiac disease था. हाँ मिल जाएगा PDF. Don't worry, I'll share it. Okay? PIH नहीं था, cardiac disease था. FMG Telegram group पे मिल जाएगा. I'll share it over there. Okay? After the session. So PIH tha ya cardiac disease tha ya both of them were in the options? If both of them were there in the options, please remember, if both of them, usually we don't use, we try to avoid oxytocin as much as possible in a patient of cardiac disease also. Okay, but in a case of PIH, we absolutely, there is an absolute contraindication of oxytocin. That is an absolute contraindication. Here also, it is plus minus only. Okay, here also it is plus minus. Here methyl argometrin or methergin. Here methyl argometrin or methergin is absolutely contraindicated in a case of cardiac disease patient. But oxytocin can be used with due risk, I'm saying. It can be used with due risk in a patient of cardiac disease. But in a patient of PIH, definitely it is an absolute contraindication. Reason being, oxytocin का mechanism of action क्या है? Oxytocin is a hormone which causes smooth muscle contraction. If it is causing smooth muscle contraction, it will cause vasoconstriction also, and if it is causing vasoconstriction, it will increase the blood pressure also. So if it is already a patient of PIH, why you would like to increase the blood pressure of this patient further? Therefore, it is absolutely contraindicated in a case of PIH. If that was not the option, cardiac disease. Okay, so cardiac disease था option में, तो cardiac disease would have been your answer. कोई दिक्कत नहीं है. No issues with this. In cardiac disease also, you will not like to increase the blood pressure of the patient, right? That can land up the patient in failure as well. That's the reason. Question number 67. A child presents to you with whitish patchy plaques on upper incisors, or some people are saying only teeth was mentioned, whatever was mentioned in the question. A child presents to you with whitish patchy plaques or on the upper incisors of the teeth, which later changes to black patches. What is the child most likely deficient in? So this kind of a picture I have got. So here the child is most likely deficient in which nutrient over here? So I hope all of you are quite aware. यहाँ पे सबसे पहले the changes start in the upper central incisors. Okay, first you will get whitish patches or whitish plaques, which will further change to blackish plaques. This image we have discussed in the classes multiple times, and this is a classical case of dental fluorosis. Okay, so please remember upper central incisors. ये लिखवाया भी था, upper central incisors is the first site of change. This was a previous year question. What is the first site for change in dental in fluorosis? So it is upper central incisors. Okay, so it is a case of dental fluorosis. Please remember, and in the case of dental fluorosis, definitely the patient will develop blackish spots over the teeth. Okay. So here the answer, it is due to fluoride. Here it should be due to excess. Okay, so it should be due to excess. Or अगर deficiency था, then it was a case of dental caries. Then it was a case of dental caries. Okay. So in both the conditions, even in fluorosis, there can be whitish patches which would be seen, which will further change to black, and in dental caries, there would be directly black patches which will appear. Okay, in dental caries, there are not whitish patches initially, there is direct a black patch which appears in a dental caries patient. Okay, so that is due to fluorine deficiency. Fluorosis, fluorine excess की वजह से, और caries, fluorine deficiency की वजह से. That's important. Okay, important. Question number 68. A child fell on an outstretched hand. I'm not sure if it was a child only. Confirm this. If it was a child only in the question, because I'm not sure about it. They are saying it was given that a child fell on an outstretched hand. X-ray was given directly. Okay, so I could not get, like, I tried to get the closest resembling X-ray possible, but problem is people were saying that the fracture was not much visible on the X-ray. Okay, it was the X-ray wrist. Most of them have confirmed that. What is the site of fracture now, they have asked. So I hope, some people are saying that Coley's fracture was mentioned in the question itself. Some people are saying Coley's fracture was not mentioned in the question. Only fall on an outstretched hand was mentioned in the question. So I'm doubtful about that. Please correct what was the age group of the patient. Second, was Coley's mentioned in the question or not. Okay? So what is the site of fracture? We know any which ways. Okay, if a patient falls on an outstretched hand, if it is a child, there is high risk of a supracondylar fracture of humerus. But here the elbow X-ray would have been given to you. Okay, it is a wrist X-ray which is given. If it is a young or an adolescent patient who has a fall on an outstretched hand, it is more likely to be a scaphoid fracture. Okay, whereas please remember, if it is an elderly patient, usually a osteoporotic female, menopausal female, then it is more likely to be a Coley's fracture. Okay, and in Coley's fracture we know it is fracture of the distal radius. Distal 1/3 of the radius is fractured. Okay, and the fractured fragment usually displaces posteriorly. Here you can see the fractured fragment is displaced posteriorly usually. Okay, so that is important, it is displaced posteriorly. Okay, that's important. So here it is a fracture of the distal radius. Some people are saying that scaphoid was in the options as well. Okay, scaphoid was in the options as well, but most people have confirmed proximal and distal was there with forward and backward going. Okay, so if that was the question, distal radius with backward displacement. Okay, so that would have been your best answer. Distal radius with backward displacement or dorsal displacement, whatever you call it. Okay, so that would have been your best answer. It is the fracture of the distal 1/3 of the radius. Okay, it was given, so Colles was given in the question itself, तो कोई दिक्कत ही नहीं थी फिर तो, ठीक है. So Colles fracture is the fracture of the distal 1/3 of the radius with backward or the dorsal displacement of the fractured fragment. No issues with this, anybody? That's easy, ठीक है. Important. Question number 69 now. A man presents to you with hernia. People with which kind of a pelvis are more prone to develop this condition? More prone, okay, to develop this condition. Usually, please remember, if it is a person, so this was a straightforward question. If it is a person with a short and a wide pelvis, okay, if it is a patient with a short and a wide pelvis, there are high risk because the pelvis could not hold, okay, and that is the reason why there is a high risk of protrusion of the abdominal contents due to the increased intra-abdominal pressure outside, okay, and that can be a risk factor for hernia as well. So if a patient is having a short and a wide pelvis, due to that reason there can be higher chances of recurrent inguinal hernia in the patient. Okay, that's important. It is one of the risk factors, a short and a wide pelvis. Question number 70. A survey was conducted on a population. Which is the most important method of estimating anemia? Was this the kind of question that came in the exam? Were they asking the method of estimating nutrition? Were they asking the method of estimating anemia? What was the exact question? So if this was the question, we know this is a previous year question. They have just framed it in some other way. The best method or the most important method of estimating anemia, iron levels or nutrition in a patient would be option B, serum ferritin levels. Okay, that's the best method to assess anemia in a patient. Serum ferritin. Okay, that's the best method to assess nutritional anemia in a patient. No issues with this, because the most common type of anemia is iron deficiency anemia, which is a nutritional anemia due to iron deficiency. And what is the most sensitive indicator of iron deficiency anemia? If they ask you, this is a repeat question, that is serum ferritin levels. Ferritin is nothing but the storage form of iron usually, right? That's important. Moving further, question number 71. Please tell me if there is any changes. Please type it in the chat box there itself. What is the denominator of infant mortality rate or IMR? I hope this was very easy. मैं हमेशा बोला है rate, ratio, proportion. We have discussed it so many times in the class itself. ठीक है? So I've always told you, if it is a rate, please remember, if it is a rate, the multiplier is always and always 1000. इतना सीधा question था, right? So I've always told you, if the multiplier is rate, the multiplier is always 1000. Okay, maternal mortality is a ratio, and the multiplier over there is 1 lakh. It can be anything ranging from 100 to 1 lakh. Okay, but usually in maternal mortality ratio, if I talk about, it is 1 lakh. In infant mortality rate, the ratio is 1000. So number of infant deaths upon the total number of live births into 1000, or you can call it the number of infant deaths per 1000 live births. Okay, so it is number of infant deaths per 1000 live births. That is the denominator of infant mortality rate. कोई दिक्कत नहीं है इसमें, right? So this is so easy. I don't think so you should have made any mistake. अगर करी है तो this is a silly mistake that you need to look up to. Question number 72. A middle-aged male died due to myocardial infarction. Okay, which of the following stain is generally used to stain the infarct? So if it is a patient of myocardial infarction, this is a previous year question. Previous year question में तुम्हें already एक important ये आया था for the stain itself and also for the types of infarction which is seen. Okay, so please remember, what is the best stain which is generally used? So first one that we have, okay, the first one that we have, please remember, it is Prussian blue, and Prussian blue इधर से उधर सबको पता है किसके लिए यूज होता है. Prussian blue is generally used for hemochromatosis, also used for hemosiderosis. ठीक है, so hemochromatosis or hemosiderosis, okay, in that condition Prussian blue is the stain used for staining iron usually. Okay, it is the stain used for staining iron generally. Please remember this. Okay, and this stain, okay, so this stain cannot be used for any infection purposes. This is generally used on liver when there is excess of iron deposited inside it in a case of hemochromatosis. Okay, Pearl's reaction is generally seen. If I talk about oil redo is the stain used for fat. Okay, Sudan black stain is the best stain for fat, but oil redo is also one of the stains which is generally used for fat. Okay, please remember. And benzene dioxide is not the best stain which can be used for infarct. Infarct के लिए previous year question है, NEET PG का question रहा है ये. So please remember, ferritin was not an option. Please give me the other options. What was the option then apart from ferritin then? ठीक है. So NEET PG में ये repeat question था. So here the best stain that is to be used, it is, please remember, triphenyl tetrachloride. Please remember it is it is the TTC which is generally used. It is triphenyl tetrazolium chloride. Okay, triphenyl tetrazolium chloride. It is the best stain. It is generally used for staining the infarct area of the heart on autopsy usually. After autopsy, तुम जब generally autopsy लेते हो heart की, so that is generally stained with TTC. Question number 73. There was some question on reticulin stain also. Please give the recall of that as well. Question number 73. A 6-year-old boy presented with periorbital and pedal edema. जो लोग बाहर आके मुझे बोले थे कि सर नेफ्रोटिक के बिल्कुल क्वेश्चन नहीं थे, लेट मी टेल यू देयर वर 3 क्वेश्चंस फ्रॉम नेफ्राइटिक एंड नेफ्रोटिक इटसेल्फ. ठीक है, यू नीड टू आइडेंटिफाई द क्वेश्चंस. इसका मतलब तुमने ढंग से पढ़ा नहीं था फिर, राइट? So there were 6 and it was so easy, like everything was given in the question itself. I hope most of you have marked it right. There was no mistake which was done from your side. A 6-year-old boy, so it is a child who is presenting to you, important finding, with periorbital and pedal edema, okay, along with ascites. So there is edema as well as ascites. That means there is extravasation of fluid, and extravasation of fluid generally occurs due to protein deficiency. It generally occurs due to protein deficiency. Please remember this. ठीक है? And due to this protein deficiency, there is decreased plasma oncotic pressure, and due to that there is extravasation of fluid that causes edema and ascites. और ये protein deficiency क्यों हो रही है? Because there is loss of proteins in the urine. There is proteinuria in this patient. ठीक है? So proteinuria causes protein deficiency which leads to edema and ascites. Light microscopy of this patient was absolutely normal. That means no change is seen on light microscopy. So no change disease, nil lesion disease. Okay, one important finding. Then electron microscopy revealed effacement of food processes of podocytes. Diagnosis is confirmed. If effacement of food processes of podocytes is seen on electron microscopy with no change on light microscopy, diagnosis is in the name itself. It is minimal change disease. Okay, so please remember which is the most common cause of nephrotic and nephritic syndrome in child. The further, it was also confirmed that the patient is responding well to steroids, and we know minimal change disease के लिए the drug of choice are steroids. The child generally responds very well to steroids as well. Okay. So what is the diagnosis? Answer is definitely MCD, minimal change disease, which is the most common cause of nephrotic syndrome in children. Okay, and in nephrotic syndrome, the child has generalized edema, also called as anasarca, due to protein deficiency. Okay, FSGS is the most common cause of nephrotic syndrome in adults, not in children. Important. Okay, otherwise effacement of food processes तो वहाँ भी दिखती है in cases of FSGS also. Okay. But in FSGS, light microscopy also shows some finding. Okay, IgA nephropathy, and IgA nephropathy is definitely not the diagnosis, because in IgA nephropathy there would be hematuria, which is a very important feature that is required for diagnosis, because it is a case of nephritic syndrome. And again, IgA nephropathy is more common in adults, and there should be history of a previous pharyngeal infection or a sore throat or a skin infection with something like impetigo. Okay, that's important. Question number 74. सरकारी question again, repeated. ये image इतनी बार repeat हुई है. A 60-year-old male presents with pain around the pelvic area and a lytic lesion in the hip bone. Some are saying femur, some are saying hip bone. ठीक है? Bone marrow aspiration reveals there are more than 40% of plasma cells. Okay, plasmacytosis है, more than 10% होना चाहिए, या more than 40% है. Serum calcium levels are definitely raised, so there is hypercalcemia in the patient which is seen. Okay, along with that, histopathological examination shows the following finding. And what is seen on the following finding? Here you can see these are the plasma cells which are seen, and these plasma cells So these plasma cells have grape-like inclusions within them. Okay, these grape-like inclusions which are seen, these grape-like inclusions are nothing but the light chain of antibodies, the kappa chains of antibodies which are produced by the abnormal plasma cells. So these light chains of antibodies accumulate within the plasma cells, and they give this grape-like appearance, grape cluster-like appearance, and these are what are called as your Mott cells. Okay, so these are known as your Mott cells. So Mott cells are usually seen on a histopathological examination. More than 10% plasmacytosis with hypercalcemia, with bony lytic lesion, elderly patient presenting to you with low back ache vagara, and Mott cells definitely confirms your diagnosis of a plasma cell malignancy or a plasma cell dyscrasia, which is called as multiple myeloma. That is a straightforward diagnosis. Crab के features में से, see, please remember, crab के features में से some were saying anemia की भी features दिए थे, but hypercalcemia और bony lytic lesions तो anyway थे ही, ठीक है, along with the diagnostic criteria which is more than 10% plasma cells and Mott cells also. ठीक है, चलो. Question number 75. TAM horsefall proteins are made up of which type of casts usually? TAM horsefall protein, first line of pathology chanting. ठीक है, ये तो डिस्कस किया हुआ है मैंने. तो TAM horsefall protein are made up of which types of casts? TAM horsefall protein are nothing but urinary cast. यूरिन में बहुत टाइप के कास्ट मिल सकते हैं, but the most common type of cast which we find in urine are the hyaline cast, and these hyaline casts are also termed as, these hyaline casts can also be termed as TAM horsefall proteins. Please remember waxy casts. Please remember waxy casts are nothing but lipid casts, and lipid casts are usually seen in a case of nephrotic syndrome, right? In nephrotic syndrome, there is hyperlipidemia in a patient that also causes lipiduria. So that lipid which is excreted in the urine, that is what is called as the waxy cast in a case of nephrotic syndrome. RBC cast, generally RBC casts are a feature of glomerulonephritis. More likely hematuria किसमें दिखता है? Nephritic syndrome. So nephritic syndrome में there would be RBC cast due to hematuria in the patient. Okay. So hyaline casts are the most common type of urinary cast, which are also called as TAM horsefall protein. Which immunoglobulin shows highest concentration range in serum? कौन सा सबसे ज़्यादा होता है सीरम में? This was a straightforward question from biochemistry. ठीक है, तो कौन सा होता है? There are 5 types of antibodies that we have, immunoglobulins. Okay. So here, what is the answer? IgA, IgM, IgG, or IgE? So please remember here the highest concentration is seen with which type of antibody? It is a very straightforward question. कौन सी? It is IgG usually. Please remember. Okay. So highest concentration अगर पूछा जाए, it is usually IgG. Okay. No issues with this. I hope so. You have marked it right. I hope so. Just a minute. So please remember, I hope it is IgG, usually IgG type 1. Okay. So that is the most highest concentration of IgG antibody type 1 is generally seen in the serum. A middle-aged female. Next question. A middle-aged female presents with headache. Radiological examination reveals there is a 2 cm frontal dura-based tumor. Okay, there is a 2 cm frontal dura-based tumor. Which of the following will most likely be observed on histopathology? I hope this is a very easy one. Middle-aged female, headache है, radio examination shows 2 cm या 4 cm जितना भी था. There is a frontal dura-based tumor. The tumor which arises inside the brain from the dural matter is definitely a meningioma. Okay, so it is a meningioma. Which of the following will be most likely observed on histopath? So I hope all of you have marked it right. Meningioma, PSM was the mnemonic. So we can see calcified concentric lamellated rings known as samoma bodies. Okay, in 3 important tumors. Okay, PSM was the mnemonic. P for papillary thyroid cancer, also papillary renal cancer. S for serous cyst adenoma of ovary. M for meningioma and malignant mesothelioma. So here definitely the answer is option D. Samoma bodies would be seen with whirling. Okay, whirling of tumor cells. I've told you, usually whirls would be seen of tumor cells. Okay, and samoma bodies would be the feature. Fried egg appearance is a feature of which brain tumor? So please remember, fried egg appearance, we have discussed this, is a feature of oligodendroglioma. Fried egg colonies mycoplasma pneumonium में दिखती है. Fried egg appearance of cells oligodendroglioma में दिखता है. ठीक है. And pseudo rosettes are a feature of ependymoma. कोई दिक्कत नहीं है इसमें. Question number 78. Which of the following remains same in all types of shock? Now, some of the options are like this. Some of the people are giving different options. Okay. So some people are giving this option. Some people are giving me cold extremities was one of the options. Okay. One of the options was cold extremities they have given. Okay. One of the options was perfusion of tissues. So I'm not sure what was the exact option, but this is what I could recollect from the students. Okay. So one thing that is low in all types of shock. What is shock? Shock is decrease in the circulatory blood volume. That is what is the definition of shock, right? Decrease in circulatory blood volume is what is called as shock. Okay? And decrease in circulatory blood volume, if it is there, definitely that means there is decreased systolic blood pressure also. And if there is decreased systolic blood pressure, there is definitely decreased perfusion of tissues as well. So if this was there, if whatever I have included, those were the options, then your answer should be option C. Systolic blood pressure would be low in all types of shock. Okay, in all types of shock, the systolic blood pressure is generally low. If that was not the option, then perfusion of tissues is also low in all types of shock. Okay, due to the decreased circulatory blood volume, there is decreased perfusion of all the tissues in every type of shock. Okay, so if it was perfusion of tissues, mark that as your answer. Decreased tissue perfusion. Now, so this should be your answer. No issues with this, anybody? Please remember. Moving further, because pulse rate will keep on increasing and decreasing. We know in neurogenic shock there is bradycardia which is seen, but on the other hand in hypovolemic shock there is a reflex tachycardia which is seen, right? So that is important. Pulse rate can differ, respiratory rate of the patient can also differ. Okay. Cold extremities or warm extremities also differ because there are different types of shock as well. Okay. So one are distributive shock and the other are obstructive shock. So if it is a distributive shock, then definitely the patient will have warm extremities. But if it is an obstructive shock, the patient will have cold extremities usually. Okay? So everything can differ except the systolic blood pressure or the perfusion of the tissues. Question number 79. A patient was in shock. The doctor noticed that urine output started decreasing. Which type of shock is it? So I hope all of you are quite aware that there are 4 gradings of shock which are given. That is mild, moderate, severe and compromised. Okay. Here definitely we know in a case of shock what is the best determinant to decide the fluid requirement, to decide the fluid adequacy. It is the urine output. Matlab you will check the urine output of the patient and depending on that you will decide how much amount of fluid should be given further to the patient as well. Okay, so urine output is the best indicator of fluid resuscitation. That was a previous year question straight away. But here this time they have just twisted the question. They have asked you urine output starts decreasing in which type of shock usually. So please remember mild shock mein the urine output is almost normal. I am saying almost normal. Okay? Whereas in compromised shock the urine output is almost nil. Okay? It is almost nil. In rest types of shock, please remember in moderate and severe types of shock the urine output is decreasing. So the urine output starts decreasing in the moderate type of shock. Normal urine output कितना होता है? More than 30 ml per kg, right? Normal urine output is more than 30 ml per kg. So if it is less than 30 ml per kg, it is usually a moderate type of shock. Okay, and if it is around 5 to 15 ml per kg, then it is a severe type of shock. So here, please remember the type of shock in which the urine output starts decreasing is the type 2 or the moderate variety of shock. Question number 80. A patient presents with sudden loss of vision. Okay. I'm not sure if they have mentioned painless or painful. Any which ways, sudden loss of vision was given and a fundoscopy image is given below. What is the diagnosis? On the fundoscopy image, now some people are saying that it was not completely white, that the retina was not appearing white. So retinal whitening was not there, but it was sure that a cherry red spot was definitely present. Okay, so a cherry red spot was definitely given. So if there is retinal whitening along with a cherry red spot, okay, with the segmental blood flow which is known as a cattle tracking sign or a box carrying sign, together this is definitely a diagnosis of CRAO, that is central retinal arterial occlusion. Okay, last time they have asked a question on CRVO. Okay, CRVO mein which appearance do we get? We get a splash tomato or a thunderstorm appearance. Okay, but in CRAO we get a cherry red spot usually. Okay, no issues with this, anybody? Sudden loss of vision can be seen in retinal detachment as well, but please remember cherry red spot is not a feature of retinal detachment. Okay, and vitreous hemorrhage mein usually you will get a boat shaped hemorrhage. Okay, you will get a boat shaped hemorrhage on a fundoscopic image in cases of VH. Question number 81, if I talk about which nerve passes at the arrow marked site. So now this is the arrow which I will mark over here. Definitely I know it was a person who was standing whose back was visible and the arrow was marked at the elbow. But all of you have confirmed that the arrow was marked at the medial epicondyle. Okay, all of you have confirmed that the arrow was marked at the medial epicondyle, and it was just asked that which nerve will pass at the arrow marked site. This was a previous year question, repeated multiple times in our sessions as well. हर बार discuss कर चुके अपन. So I hope so here the answer was quite easy. It was option A, ulnar nerve. Okay, so just behind the medial epicondyle the ulnar nerve passes. So if there is a fracture at the elbow or there is a fracture of the medial epicondyle, there is a highest risk of ulnar nerve injury usually in the patient. ठीक है. Question number 82. The following image is due to defect in the fusion of. What is this image suggestive of? This image is suggestive of a failure of fusion of the lip. So this is a case of cleft lip. Okay, so the lip is not able to fuse properly. This we have discussed in surgery as well, and in anatomy के embryology वाले में video में भी discuss किया है मैंने, right? So please remember, cleft lip is due to defect in the fusion of two processes. Which two processes are not able to fuse? The medial nasal process and the maxillary process. If they do not fuse with each other, then definitely there would be a cleft lip which can occur in the patient. Please remember. Okay, so if the medial nasal and the maxillary process do not fuse with each other, then that leads to cleft lip in the patient. No issues with this, anybody? Question number 83. Ovarian drilling procedure is done for. This was a straight one liner. They told me, most of the people have recalled it, कि ovarian drilling procedure पूछा था sir, and it was just asked ovarian drilling procedure is done for. I hope ये हमने क्लास में भी डिस्कस किया है कि if a patient of PCOD is not responding to medical therapy, तो सबसे पहले तो lifestyle modifications करोगे. If not responding to that, then you will definitely go for some drugs, medications like metformin वगैरह. If you need ovulation induction, the best drug that we use is letrozole or clomiphene citrate. If the patient is not responding to the drugs, definitely what is the problem? That even though it is getting the stimulus for growth, what has happened? Due to the thick ovarian stroma, these small follicles which are placed in the periphery, they are not able to grow properly in size. So we need to actually make holes in this thick ovarian stroma. Okay, तो हम क्या करते हैं? होल्स बनाते हैं थिक ओवेरियन स्ट्रोमा में, इतने भी नहीं, ठीक है. सो ओवेरियन स्ट्रोमा में होल्स आर मेड so that the follicles will get enough space to grow, okay, and they will enlarge in size, and therefore ovulation can occur. So laparoscopic ovarian drilling procedure is generally done for a case of PCOD, polycystic ovarian disease or polycystic ovarian syndrome. No issues with this, anybody? Important. Question number 84. A patient reports to you that an alien is inserting a thought in his mind to kill his neighbors. The person is oriented to time, place and person. Due to this, people are saying if the patient is oriented, it cannot be schizophrenia. I'm just not sure how many people of schizophrenia have you met until now, and how many people of schizophrenia or how many patients of schizophrenia were disoriented. So please remember, not every patient of schizophrenia would be disoriented to time, place and person, guys, right? So like this is not a criteria to rule out schizophrenia, first of all. Okay, so a patient of schizophrenia would be oriented to time, place and person as well. The person is likely suffering from. So please remember, what is this characteristic picture that they have given in the first line itself, that an alien is inserting a thought in his mind to kill his neighbors. So if somebody else is inserting a thought in your mind, okay, that is what is called as thought insertion. And thought insertion is one of the features of thought alienation symptoms. Okay, thought alienation तीन type के होते हैं: thought withdrawal, thought broadcast and thought insertion. And these three important thought alienation symptoms are considered as important symptoms of first rank Schneiderian first rank symptoms of schizophrenia. Therefore, definitely this is a likely feature of schizophrenia itself in the patient. Please remember this. No issues with this, anybody? और मुझे ये बताना, कौन सा delusion का patient disoriented नहीं हो सकता? So this is not a basis to differentiate schizophrenia and delusion. Delusion में क्या है? Delusion में the patient definition से याद रख लेना. मैंने last time भी इसलिए psychiatry लिया था in the QRS itself. I've told you delusion is what? Delusion is a firm, fixed, unshakable belief which continues despite evidence against it and which is not explained by the socio-cultural background of a patient. Okay, so here it cannot be explained by the socio-cultural background of the patient, that I understand. Okay, here the patient is not having a belief, here rather the patient knows that somebody is inserting a thought in his mind. So इधर ही तो वो rule out हो जाता है कि delusion cannot be the answer. Okay, delusion usually in delusion the patient is not agreeing कि कोई मेरे दिमाग में thought डाल रहा है, वो मेरा thought है और ये सही है, that the patient knows. ठीक है, so delusion could not be an answer at any cost. Please remember this. ठीक है, other options I'm not sure about. Please let me know the other options if you're sure about them. Question number 85. Please let me know the options for this one as well. So here what I have got is which rule is applied if a person applied if a person when out of his mind commits a crime. So they said insanity or insane person was not mentioned in the option, rather they mentioned that if a person is out of his mind and he commits a crime, then which is the rule applied. And I hope in Vikas sir I have included this in definitely multiple times in his sessions. He have told you that McNaughton's rule is definitely, it is the rules for criminal responsibility of an insane person. For example, if an insane person during an insanity episode commits a crime, he will not be held responsible for his crime. That is what is the McNaughton's rule says, and it is covered under which IPC? That was the previous year questions. It is covered under section IPC 84. Okay, it is covered under the IPC section 84. Okay, it is nothing but the McNaughton's rule where the insane person is not held criminally responsible for his crime. ठीक है, याद रख लो. Please मेरे हिसाब से the other options would have been Royal Seema phenomena वगैरह. Please let me know if they were there in the options. Question number 86. A 52-year-old female comes to the OPD with complaints of knee pain since the last month. She gives a history that the pain aggravates while sitting. On examination, there is swelling around the knee joint, and a synovial fluid examination reveals that there are needle-shaped crystals. There are needle-shaped crystals with negative birefringence. Most important. ठीक है? So, what is the most likely diagnosis? What have you marked for this? That I need to know, because a lot of people, I'm not sure, have you watched my integrated sessions or not? Over there, I've clearly mentioned, like, there are two important different things that you need to remember. Okay, crystals of uric acid in this one, in the kidney are different, and the crystals of uric acid in the joints are different. Okay, so please remember, if you are getting negatively birefringent crystals, needle-shaped crystals in the joint, then it cannot be a diagnosis of pseudo gout. मैंने दोनों compare करके पढ़ाया था बकायदा. Gout and pseudo gout I've compared with for you. Please remember, in both the conditions the patient will have swelling around the knee joint, the patient will have pain around the knee joint. Okay, and once the investigation of choice for both of them is joint aspiration. Once you aspirate the synovial fluid and send it for examination, on examination if you see needle-shaped crystals, okay, if you see needle-shaped crystals and if you see rhombic crystals, there's a different findings, right? Needle-shaped crystals are suggestive of gout, rhombic crystals are suggestive of pseudo gout. Further, if you actually take them under polarized microscopy, if they are negatively birefringent, they are gout. If they are positively birefringent, then they are pseudo gout. Okay? So that was a clear-cut question. The answer over here should have been option B, gout. Osteoarthritis when the patient only complains of knee pain. Synovial fluid examination will not show any needle-shaped crystals as such. Synovial fluid examination might show you some osteophytes as well. Okay, some bony fragments, ankylosis जिसको बोलते हैं, free fragments of bone, that can be seen in the joint. But crystals, needle-shaped crystals are not a feature of osteoarthritis. ठीक है? Please remember this. Osteoarthritis definitely it is common in older females. It is common in the knee joint. But joint aspiration does not show needle-shaped crystals and negative birefringence. Okay, gout के 2-3 questions हैं. I've always told you gout is important question from pharma as well and from medicine as well. So please read it properly. A female presents to you with a lump in the breast with mobile axillary lymph nodes, which later on progresses into the below given image finding. Now I've tried a lot to find that particular image. I've taken help of each and everyone almost. But nobody was able to send me nobody was able to find that exact image. So it was some image of the breast which was given with some signs of inflammation. People are sure that there were some signs of inflammation. Okay, so there were some signs of inflammation which were there. Okay, I tried to show them each and every image of inflammatory breast cancer or cancer and curers, but nobody was sure. Only they said there were signs of inflammation. Okay, that was usually seen. So if there are signs of inflammation and there is a history of breast lump in the patient, okay, which has progressed to the lymph node involvement as well, definitely that is the case of breast cancer. So now they are asking you the TNM staging of breast cancer over here, and the breast cancer which leads to inflammatory signs, that is definitely an inflammatory breast cancer which is T4D staging. Okay, that has the worst prognosis. So T4D is the worst prognosis. Okay, it is inflammatory breast cancer. So here they said that there was some XYZ something like that which was mentioned before the T staging. Okay, and then it was T1 N0 M0, T1 N0 N1 M0, T4 N1 M0 and T3 N0 M0. Now some people are saying there were two options of T4. Okay, there were two options of T4, but some people have said that there was only a single option of T4, and therefore if single option was T4 was given, then definitely the diagnosis would be T4 N1 M0 in this condition. Okay, please remember. No issues with this, anybody? Question number 88. Which of the following pathways only occurs in cytosol? कौन सा pathway बस cytoplasm में किया होता है? So please remember, we know there are two types of pathways. One which are responsible for breakdown are called as catabolic pathways. One which are responsible for synthesis are called as anabolic pathways. Right? So we know catabolic pathways से क्या बनेगा? ATP बनेगी, एनर्जी बनेगी. So एनर्जी कहाँ बनती है? ATPs कहाँ बनती है सेल में? Mitochondria में, because mitochondria is the powerhouse of the cell. So please remember, catabolic pathways are carried out in the mitochondria, whereas anabolic pathways are carried out in the cytosol. But there are some exceptions, right? There are some exceptions. Yes, all the catabolic pathways, breakdown pathways are carried out in mitochondria, except which are the two pathways which are not carried out in mitochondria. One is glycolysis and second is glycogenolysis. So glycolysis and glycogenolysis are the two catabolic pathways which occur in the cytoplasm. Please remember this. No issues with this. Now there are two important vital cycles, that is TCS cycle and electron transport chain, ETC. They will always and always occur in the mitochondria because they are vital cycles of the cell. They will occur in every phase, fed, fasting, starvation. हर एक phase में वो होते रहेंगे. So therefore TC and ETC will always and always occur in mitochondria. So TCA cycle occurs in mitochondria. Beta oxidation of fatty acid. It is the breakdown pathway of fatty acid due to which ATP is produced. So ATP अगर produce हो रहा है, so it occurs in mitochondria. DNA synthesis occurs in the nucleus. Okay, so the only option that we are left with is glycolysis. Though it is a catabolic pathway, it occurs in the cytoplasm. No issues with this, anybody? I hope so. This was very clear and easy as well. All of the following are components of RCH, that is reproductive and child health program, except. So this were the options what I have got. So option A says women education and women empowerment. Okay. Option B says child admission in hospitals. Okay. Child admission in hospitals, definitely, because the childhood illness is definitely included under RCH program. Okay. The criteria on which the RCH program works is this one, RMNCHA, that is reproductive, maternal, neonatal, childhood health and adolescent health. A was asked prior, that A stands for adolescent health. So definitely it is responsible for childhood health, and therefore the hospital rate, hospital admission rate of children are definitely included under, or it is a component of RCH program. Reduction in infant mortality rate, as I've told you already, it also works for the neonatal and childhood health. Definitely reduction in infant mortality rate is an important component of RCH program, rather a best indicator of RCH program. Whereas better maternal care is also included under RCH program. But women education and empowerment is not included under RCH program. Rather, we have a separate program for it. Either it is included under the Sarva Shiksha Abhiyan, okay, or Beti Bachao Beti Padhao Abhiyan. Please remember, there are different Abhiyan. It is not included under the RCH program. Here in RCH program, education is given, but that is the preschool education is given, and to everybody, not only to girl child, it is given to everybody, right? So that is not, women education and women empowerment are not included under the RCH program. Question number 90. Identify the instrument. So somewhat it was a trick because they have given Piper's forceps and outlet forceps also in the option. Please remember, here if the handle was longer, if the handle would have been longer, then definitely the answer would have been your Piper's forceps. But as the handle, as you can see over here, it is very short, so this is actually the outlet forceps which are used for augmentation of delivery in the patient. Okay, so these are definitely called as the outlet forceps. No issues with this, please remember this. ठीक है, याद रखना. Other two options, please recall if you are able to recall it. Question number 91. Which of the following drug increases longevity in a patient with heart failure? So if a cardiac failure patient, okay, आता है तुम्हारे पास, so which of the drug you will give that will increase the longevity of this patient? Okay, so the drug which is responsible for cardiac remodeling, or the drug which increases the longevity of the person, one and the same thing. Previously उन्होंने cardiac remodeling के लिए पूछा था, now they have asked the drug which increases the longevity. So here if a patient of heart failure is there, okay, his heart is already weak, his heart is not able to pump the amount of blood which is required. Okay, so in case if we give a drug which will increase the heart rate of the patient, जब heart rate बढ़ेगा तो क्या होगा, the myocardial oxygen demand will also increase, and if the myocardial oxygen demand increases, definitely the patient will rather than increasing the longevity, the patient can again go into heart failure. Okay, please remember, if the heart is not able to fulfill the increased myocardial oxygen demand, therefore we need to give a drug which will decrease the heart rate of the patient, therefore the myocardial oxygen demand will decrease, and the chances of heart failure will decrease, and the longevity of the patient will increase. So the drug which decreases the heart rate, we know these are beta blockers, and the drug which is a cardioselective beta blocker which is given, it is option B, metoprolol. Okay, so metoprolol is known to decrease the heart rate, therefore decreasing oxygen demand, and therefore increasing the longevity. No issues with this, anybody? I hope that was pretty easy. Question number 92. Which of the following drug is used to decrease the progression of lung fibrosis and increasing exercise capacity of a person? Now these are the questions which are called as googly. Definitely there would be some times that these type of questions will appear in the examination. अब फार्मा के बाकी सब इतने इजी अगर क्वेश्चंस दे दिए, तो एक दो अगर ऐसे क्वेश्चंस आ भी गए, तो दे आर नॉट द डिसाइडिंग फैक्टर्स. आई हैव ऑलवेज टोल्ड यू. ठीक है, तो नो इश्यूज विद दिस. इफ यू आर नॉट एबल टू मेक इट आउट एज वेल, इट्स फाइन. So the drug which will decrease the progression of lung fibrosis, okay, it is a drug known as pirfenidone. This pirfenidone, it is actually a inhibitor of sorry, it is actually an inhibitor of growth factors usually, okay, and procollagens. So it will inhibit procollagen and growth factor. As growth factors are inhibited, or the procollagen is inhibited, therefore the fibrosis would be slowed down. Okay, so therefore the risk of fibrosis or the progression of fibrosis is slowed down, and therefore pirfenidone is the drug which can be used in a case of lung fibrosis or pulmonary fibrosis. That will also help in increasing the exercise capacity of a patient. No issues with this, anybody? Roflumilast is an inhalational drug. ये question पहले आ चुका है. It is usually used in a patient of COPD. It is a phosphodiesterase 4 inhibitor. ठीक है, so it is a phosphodiesterase 4 inhibitor which has anti-inflammatory actions. ठीक है, so it has anti-inflammatory actions, and therefore it is used in a patient of COPD as well. ठीक है, roflumilast. Imatinib, we know it is a tyrosine kinase inhibitor used in cases of multiple myeloma, used in cases of chronic myeloid leukemia, and bortezomib is a proteasome inhibitor which is used in a case of multiple myeloma. Question number 93. A 68-year-old male cancer patient on chemotherapy developed neutropenia. तो उसको neutropenia हो गया. There is decrease in the neutrophil levels of this patient. Which of the following drug is used in this patient to increase the immunity? So this is a recall question. FMG का recall question है. सीधा सीधा. I don't think so. You should have made a mistake in this. If the patient is having neutropenia, अब कुछ लोग ये बोल रहे हैं कि the patient was having neutropenia, then he was treated with some drug due to which now he is having leukocytosis. Whatever the question was, finally उन्होंने यही पूछा था which drug is used in neutropenia or which drug can increase the level of WBCs in the patient. Okay, and the drug which can increase the level of WBCs, we know it is a drug known as filgrastim. It is a granulocyte stimulating factor. Okay, so grastim में ही है. It is a filgrastim granulocyte stimulating factor. So definitely filgrastim is a drug which is generally used in a chemotherapy or a radiotherapy induced leukopenia or neutropenia in a patient. The other drug that can be used, it is called as sargramostim. Okay, but it is a granulocyte monocyte stimulating factor, वो दोनों को stimulate करता है. It will increase neutrophil levels as well as monocyte levels as well. That is sargramostim. Darbepoetin is a erythropoietin analog. So if a patient is having a severe anemia, usually due to kidney disease or usually due to chemotherapy or radiotherapy, then definitely erythropoietin analog like darbepoetin can be given to the patient as well. ठीक है? Oprelvicin is usually used to increase platelet count in a patient. ठीक है? No issues with this, anybody? A patient planned to receive chemotherapy with cisplatin. Which of the following drug is used for treatment of chemotherapy induced nausea and vomiting? इतनी बार तो फार्मा में रटवा दिया ये. I don't think so. There should have been a mistake in this. What was the answer for this question? And now I'm not sure. A lot of people were saying there were like these options, but some people are saying there was only one drug in each option. So let me know. So I hope all of you are quite aware. Drug of choice for chemotherapy or radiotherapy induced nausea or vomiting or post-operative nausea and vomiting. The drug of choice are 5-HT3 antagonists. And these 5-HT3 antagonists are nothing but the cetron drugs. That is your granisetron, ondansetron. Okay, these cetron drugs are definitely given. But if the patient presents to you with a delayed vomiting, usually after 72 hours, matlab a patient was given some chemotherapy and after 72 hours the patient is having vomiting. Okay, this is generally seen with cisplatin. Cisplatin, we know it is the most emetogenic anti-cancer drug. सबसे ज़्यादा risk of vomiting in किसी भी anti-cancer drug में दिखता है तो वो cisplatin के साथ दिखता है. Cisplatin generally causes delayed vomiting. So cisplatin causes delayed vomiting. For that we need some substance P antagonist. Okay, we need substance P antagonist or neurokinin antagonist, and these drugs are pitant drugs. Okay, pitant, aprepitant. So these are the pitant drugs which will be required. And definitely like while we start chemotherapy to a patient, steroids are also given, dexamethasone, because steroids or dexamethasone have shown efficacy in decreasing the post-op or post-chemo nausea and vomiting in the patient. Okay? So the best answer over here, where we have cetron and pitant in the same option, that was the answer, even if you are not sure with dexamethasone. Okay? So here the answer would have been granisetron, aprepitant and dexamethasone. Okay? Question number 95. A patient of colorectal cancer was treated with 5-fluorouracil, folinic acid and irinotecan. Folfini regime जो होता है. Okay, so folfini regime was used for this for the chemotherapy of colorectal cancer in this patient. He developed diarrhea following the regime. Which of the following will be useful for the treatment? So this is actually again a chemotherapy induced diarrhea. So chemo induced diarrhea के लिए which is the drug of choice they are asking. So chemo-induced diarrhea, I hope all of you are quite aware, it is not a bacterial or it is not an amoebic diarrhea, right? It is not an infective diarrhea. So if it is not an infective diarrhea, why to give any antibiotics or anti-amoebic drugs like ciprofloxacin or metronidazole respectively, right? So these drugs are to be avoided. Definitely the best drug that we have is loperamide. Loperamide, I hope all of you are quite aware, it is an opioid agonist, okay? And it is an opioid agonist and it mainly acts on which receptors? It is an opioid agonist which acts on the mu receptors which are located inside the gut. Okay, and it acts on this mu receptors, it stimulates this mu receptors inside the gut, and therefore it decreases the intestinal motility. As it decreases the intestinal motility, the risk of diarrhea decreases and it increases the intestinal transit time of the food. मतलब जो time food intestine में बिताता है वो increase हो जाता है usually, right? And therefore one of the side effects क्या था of any opioid? C stands for constipation, na? So any opioid agonist can lead to constipation in the patient. Okay, so please remember loperamide is used for diarrhea in the patient. याद रख लेना. It is also used for any non-infective diarrheas. Okay, it is also used for any non-infective diarrheas in a patient. And usually we try to avoid metronidazole and loperamide together. तो दोनों एक साथ मत दे देना patient को. Either give metronidazole if you are thinking in terms of an amoebic diarrhea, or give loperamide if you are thinking in terms of a non-infective diarrhea. Question number 96 now. A patient is suffering from depression, started on an antidepressant drugs which leads to erectile dysfunction. Which of the following is least likely to cause any sexual side effect? So they have given you all psychiatric drugs, okay, and they are asking which among the antidepressant drugs have least chances of any sexual side effect. Okay, so usually most of the antidepressant drugs have high risk of sexual side effects. These sexual side effects can range from something like erectile dysfunction. It can also cause a painful persistent penile erection, which is called as priapism. It can also lead to penile anesthesia, loss of sensations in the around the penis or the glans. It can also lead to loss of libido in the patient, that is decrease in the sexual desire in the patient. Okay? So all of these sexual side effects are associated with antidepressant drugs. And which are the antidepressants which can cause it? So it can be either a tricyclic antidepressant, drugs like imipramine, clomipramine वगैरह. Then it can be drugs like SSRIs, okay, that is selective serotonin reuptake inhibitors, which are used for mild depression, mild to moderate depression. And rather we know like SSRIs are the SSRIs have a important side effect of delayed ejaculation as well. Okay, they have an important side effect of delayed ejaculation as well. Therefore, in cases of premature ejaculation, we will go for SSRIs as the drug of choice usually. Duloxetine is the drug of choice that is here generally used. No issues with that. So, venlafaxine is a serotonin norepinephrine reuptake inhibitor. So, serotonin norepinephrine reuptake inhibitors like venlafaxine, desvenlafaxine, definitely these are also known to cause sexual side effects. So, SNRIs, SSRIs and TCAs are known to cause sexual side effects, except bupropion. Please remember bupropion, which is actually a norepinephrine dopamine antagonist. Okay, so reuptake inhibitor. So it is a norepinephrine dopamine reuptake inhibitor. Usually these are the ones. Okay, so bupropion norepinephrine dopamine reuptake inhibitor hai. I'll come back to that question. Okay, so definitely then in this condition bupropion is rather known to increase the libido in the patient. Okay, it will help in increasing the sexual desire of the patient. So therefore it is definitely not causing like features of erectile dysfunction or any sexual side effects as such. Okay, please remember that. So least likely bupropion is the drug which is known to cause this. Okay, and bupropion, I hope all of you are quite aware, it is also used for, as it acts on the nicotinic receptors also, it is used for smoking cessation in the patient as well. Okay? Question number 97. A 22-year-old female with bipolar disorder was on lithium tablet or lithium therapy. Which of the following statement about the therapy is not correct? Which among the following statement is false, they were asking. Option A says lithium decreases thyroid function. Yes, lithium is known to decrease thyroid function, or it can also increase thyroid function. So lithium एक ऐसी drug है which can cause hypothyroidism also, hyperthyroidism also. That is the important side effect of lithium. Okay, so lithium can cause both. Option B says lithium toxicity increases with thiazides. The reason being, क्यों thiazides ये करता है? Please remember, thiazides cause loss of sodium. कहाँ पे? It acts on the DCT, ये मैंने बता दिया. So it causes loss of sodium in the DCT. Now as we know, बॉडी सोडियम का लॉस झेल सकती है क्या? नहीं. Therefore, to overcome or to compensate this loss of sodium, the body tries to reabsorb sodium mostly from which part of the nephron? From the PCT. From the proximal convoluted tubule, body tries to reabsorb more and more amount of sodium. But along with sodium, with the same co-transporter, lithium is also absorbed. And that is the reason why if you give thiazides to the patient, the body will try to reabsorb more amount of sodium along with lithium, and that can cause lithium toxicity in the patient. Okay, option C says hemodialysis is not useful for lithium overdose. Rather, for lithium toxicity, hemodialysis is the treatment of choice. Okay, please remember, for some drugs like digoxin and lithium, okay, for lithium toxicity, definitely hemodialysis is the treatment of choice that has to be used. Please remember. So this is a wrong statement or a false statement. Lithium is avoided in pregnancy due to teratogenic side effect. सरकारी क्वेश्चन पूरी दुनिया को पता है. Yes, it causes a teratogenic side effect on the fetus known as Epstein's anomaly, which leads to a box-shaped heart. So here the exception is option C. Question number 98. Which of the following antidyslipidemic drug acts via stimulation of the PPAR alpha receptor? Okay, so this PPAR alpha receptor, peroxisome proliferator activator receptor, alpha receptor usually. Please remember, these drugs are usually fibrates. Okay, so fibrates are the drugs which generally act by stimulating this PPAR alpha receptor. Okay, so once these receptors are stimulated, they will actually decrease the triglyceride synthesis. And if they ask you which are the best anti-dyslipidemic drugs to decrease triglyceride synthesis, answer is fibrates itself. Okay, so fibrates are the best drugs to decrease triglyceride synthesis or triglyceride levels in a patient. So answer over here is fibrozil, जिसके भी नाम में fiber आता है, that is a fibrate, gemfibrozil, clofibrate, okay, all of these drugs. Atorvastatin, definitely statins are the best drugs for dyslipidemia or hyperlipidemia, okay, but please remember atorvastatin act by inhibiting the Hmg coenzyme A reductase. They will act by inhibiting the enzyme known as Hmg coenzyme A reductase, which is the rate limiting enzyme of which pathway? This is the rate limiting enzyme of cholesterol synthesis. Okay, that's important. Ezetimibe will inhibit the intestinal absorption of cholesterol. तो intestine में जो absorption होता है cholesterol का, that is inhibited by ezetimibe. ठीक है? So that each and everything we have discussed in pharma also. अभी recent test and discussion में भी discuss किया है. So I don't think so you would have any doubt. Niacin is the best drug to increase HDL levels in the patient. Niacin is the best drug to increase the HDL levels in a patient. No issues with this, anybody? Question number 99. Which of the following is used for initial management of irritative urethral syndrome of BPH? Okay. So for initial management of irritative urethral syndrome of BPH, finally they want to ask benign prostatic hyperplasia patient ko. Okay. And the patient due to that is having some irritative urethral syndrome. That means the patient is having intermittency, the patient is having hesitancy, the patient is having urinary retention. All of these are features of irritative urethral syndrome itself. Okay? So for this, what is the initial management? याद रखना हमेशा, if it is a case of BPH, usually we will try to start with drugs itself. Restricting water intake will not help the patient. Okay, अगर तुम बस water intake कम कर दोगे patient का, the size of prostate is still increasing. Okay, that will further causing urinary retention and all of the other features. ठीक है, so restricting water intake is not the best or management. Okay, it is not a part of the protocol of management. So restricting water intake is out of the question. ठीक है, prostatectomy is not the initial management that we will use. Okay, so usually prostatectomy is done for cases of prostate cancer. Okay, so if it is the prostate cancer in the early stages, then we will go for a prostatectomy. If it is an advanced prostate cancer which has been metastasized vagara, then we will go for a hormonal therapy that we all know, right? So here it is not an initial management. TURP, that is a transurethral resection of prostate, it is done for BPH, but it is not again an initial management. If the medications fail, then only we will go for a TURP in the patient, or if the symptoms are so severe that they are not able to improve with the drugs itself. Otherwise, the first line management is always medications, that is alpha blockers, and we know which alpha blockers are given. Selective alpha 1 blockers are generally given, and selective alpha 1 blockers are drugs like prazosin. Okay, those are given, but those will lead to a side effect like orthostatic hypotension. So prazosin is given to a patient of BPH plus hypertension. If it is a normotensive patient of BPH, no hypertension, but the patient is having BPH, then we will go for a more selective drug, and that selective drug is called as a selective alpha 1A blocker, which will not act on the blood vessels, will only act on the prostatic urethra, and these drugs are called as tamsulosin. That is the drug of choice for BPH for the initial management. कोई दिक्कत नहीं है इसमें. Question number 100, easiest question. Inhalational anesthetic agent of choice in children. Dr. Vinayak would have also covered it in anesthesia. हमने pharma में cover किया है, और तो इसमें कोई doubt ही नहीं होना चाहिए. Inhalational anesthetic agent of choice in children is definitely sevoflurane, both for induction as well as for maintenance, right? So induction as well as for maintenance in children, the anesthetic agent of choice is sevoflurane itself. 101, a HIV patient presents with seizures and neck rigidity. CSF examination shows presence of organism on India ink stain. Okay, so India ink stain में क्या होता है? It is a negative stain which will only stain the capsule of an organism. So the capsule of an organism is stained, and then further diagnosis might be done, because India ink stain does not confirm it to be cryptococcus. ठीक है? Further diagnosis like ELISA या lateral flow assay would have been done for cryptococcal antigen, and that confirms the diagnosis of cryptococcal meningitis. Which of the following is the initial treatment of this patient? So definitely we know in a HIV positive patient who is an immunocompromised patient, there is a high risk of fungal infection, severe fungal infections, and here the patient has acquired a severe fungal meningitis, and the most common cause for it is, we know it is Cryptococcus neoformans itself. So the patient is having cryptococcal meningitis. Okay, India ink stain is used for rapid diagnosis of Cryptococcus, not for the best investigation. Which of the following is the initial treatment? So what would be your answer? For any severe fungal infection, we know the best treatment or the best drug drug of choice for any severe fungal infections, we have always discussed, it is liposomal amphotericin B, LAMB. Please remember, it is LAMB usually. No issues with this, anybody? That's important. Okay? Because cryptococcal meningitis is a very severe fungal infection, right? Because it is spreading up to the brain as well. Last question for today, question number 102. Which nutrient deficiency can lead to collagen defect? कौन सा nutrient deficiency causes collagen defect? We know this, that we have discussed multiple times. Collagen is the most abundant protein inside the human body. It is made up of 3 amino acids mainly. The most abundant is glycine because every third amino acid is glycine. ठीक है, इसके बीच में एक तो प्रोलीन आएगा, लाइसिन आएगा, हाइड्रोक्सीप्रोलीन आएगा या हाइड्रोक्सिलाइसिन आएगा. To make the collagen stronger, we need hydroxylation of proline and lysine, and this hydroxylation of proline and lysine is generally done with the help of vitamin C and copper. So याद रखना, with the help of vitamin C and copper, these are the two important constituents which are required for hydroxylation of proline and lysine. If these are deficient in the patient, hydroxylation will not occur, and if hydroxylation will not occur, lysyl oxidase is the enzyme which is used. And if hydroxylation does not occur, then the collagen which is produced would be defective collagen, and therefore there would be higher chances of brittle hair, gum bleeding. Okay, so all of these features would be seen. So definitely it is due to vitamin C deficiency, that is ascorbic acid deficiency. Some people are saying copper was also there in the same option, so that would be your best answer. Okay, no issues with this. I hope we have covered a lot of questions. I'll try to come up with one more session with majority of the questions. Okay, so thank you so much, and I hope all of you have been able to solve most of the questions correctly. Okay, we have tried to give our best. Okay, from the faculties also, they have given everything in FMG from the notes. Most of the things were covered. Okay, like 80-85% things were exactly there. QRS में बहुत सारे questions cover हो गए थे तुम्हारे. Okay, even in the test and discussions that we conducted, or that those were conducted on the app also, most of the questions were there. So hopefully you will have great results and you will come out with flying colors. Let's meet in the another session. Till then, goodbye and good luck from FMG. Thank you so much. (36) में अगर एसिड फास्ट होता तो ट्यूबरकुलस मेनिंजाइटिस इज कंफर्म्ड देन, तो ना सॉरी ट्यूबरकुलस मेनिंजाइटिस बोल रहा हूँ, मैक इज कंफर्म्ड देन. ठीक है, कोई दिक्कत नहीं है इसमें. चलो, थैंक यू सो मच.